Committee Room 29. Sound.
Members and those in the public gallery that they're welcome to use your mobile devices as long as they're in airplane mode and all devices are muted, and you can connect to the Assembly Wi-Fi, but it's not permitted to take photographs or record any of the meeting. I have two apologies from Orlia Flynn and Nuala McAllister. I have Linda Dillon and Alan Robinson who have joined online, and I don't think our members are aware of any other apologies. I think the only other person we're waiting on is Alan Chambers, so he may still join. Can I just thank Linda for taking the chair last week at short notice. I wasn't able to make it, but I appreciate Linda stepping in my absence, and also just to send our best wishes to Orlea's wee boy. I think he's been discharged from hospital just today. They've had a rough old time of it, I think, as well. So just to send our wishes to them. Just a couple of things under Chair's business. I want to acknowledge that yesterday was Organ Donation Discussion Day, and it's just another opportunity and reminder to have the conversation around organ donation. For anyone that heard the radio this morning, Marcie McGowan, wee Dahi's daddy, was on again, just re-emphasising how important that is, and particularly for children like Dahi who are waiting long time on crucial organ donation. And we are due to meet with Donate for Dahi on the 9th of January as part of the informal sessions with some of the stakeholder groups. So we can hear some more around that at that time. This morning I was invited through the Royal College of GPs to meet some of the GP practices. So I was at Willowbank Surgery in Katy. It was a really worthwhile visit, just meeting with the GP, the practice manager and some of the staff, and just to really see at the cold face some of the pressures our GP services are facing in a fantastic facility. It's only open 2 years, but still the huge volume of work that GPs and practice staff are undertaking. I think it was a bit of an eye-opener even for me, because we have heard lots of evidence around this, both at committee, through events here in the Assembly and through constituents. But even at that, I think there's so much more involved that we probably don't realise, and it is more critical than ever that GP services and GP practices get the support they need to deliver the really high quality of care that they want to be doing. As well as that, I just wanted to refer members, we had an informal meeting Tuesday week ago with the Patient Client Council SII engagement panel, and we had a really good discussion with those members of the panel on the SII process and the redesign of the SII framework, which is a core part of our work and one of our strategic priorities as a committee. So if members are content, I was going to suggest that we write to the department to request a detailed timeline for progress of the redesign work, and how recommendations from the various inquiries will be implemented by the framework, and further information on what co-design work has taken place and who's been involved in that, because I know that is some of the concerns that were raised on the day. And I know the Minister this week launched a public consultation into the redesign framework as well, which they had referenced at their meeting. So are members happy with that? Linda, did you want to come in on that?
Thank you, Chair. I really appreciate you letting me in, because unfortunately I have to leave early. But if I can just say at this point, I think that is even more important than ever now. Obviously, it wasn't specifically around the cervical smear issue, but we know that the reports came out yesterday from both the Southern Trust and the PHA. And can I suggest that we write to the Minister as a committee and ask for the terms of reference for the independent review, and also the terms of reference for NHS England's review of the systems. So there are two different reviews, and I would like us to get access to the terms of reference of both of those. Yep. I know that it is the intention of some of those ladies impacted to get in touch with the Minister. They are calling for a statutory public inquiry, and they're going to approach the Minister themselves in relation to that. So I think we should allow that process to take its course, but I would like to understand what the terms of reference of those two reviews are.
Okay, no problem. I have no problem with that, Linda. I was going to come in on the cervical smear update this week anyhow, so I know Diane wants to raise something on it. So I suppose just to highlight that press release this week, and I suppose particularly the fact that 8 women have sadly died, or have sadly developed cancer. 2 of those have died, and I think that's been very stark reading for many of us. Unfortunately, I wasn't able to attend the briefing this morning due to the visit to Willowbank, but I think, Deanne, you wanted to come in on that issue.
Yes, thank you, Chair. Yes, I wasn't able to attend the briefing this morning either, but this is a really serious issue. 8 women have developed cancer, 11 other women had to have interventions and are currently being monitored. 2 women have died, and the Trust knew about this from 2008. And the report actually says that there was really a lack of action from the Trust. And I think as a scrutiny body of what's going on in health here, that the Trust should come before the committee and the Public Health Agency and explain why they failed so many women over such a long period of time. And I think that would be best done as soon as we can possibly do it. I think that we would fail as a committee if we didn't ask questions into that. 17,500 smears were reviewed in this case. That is a huge number. And we need to know what the failings were in the Southern Trust. And we need to know from the Public Health Agency that this service, that women can have confidence in it going forward. No, so I think it's really important to bring the two to the committee.
Yes, I'm happy to have that arranged, and as you said, maybe as soon as we can. I know we do have a meeting scheduled in Daisy Hill on January the 23rd. Our committee meeting is going to be in Daisy Hill. So if we can look at those dates, those earliest dates in January that we can. I think it's very critical. As well as that, Ladies with Letters had reached out to meet with the committee, so that is being organised as well. And I know I'm meeting with them separately.
Can I just be an annoying twist on the end of that, which is that, I think sometimes we're going to get the Trust in, and I've heard them before, and I'm not doubting what it is that they're saying, but I can nearly write what they're going to say on this issue. But we have a very complicated topography of health services here, but the department is supposed to be in charge. Is there anybody from the department that could be at that meeting as well to say that if a trust does something, at what point does the department step in and say, well, we're the parent organisation here? I'm not deliberately not saying that it's maybe the minister, because the minister wasn't in position then, and I don't want it to be seen to take away and it be a grilling of the minister. But fundamentally, if this was anywhere else, it's the minister that's in charge, it's the department that's in charge, and for the department to just keep going, no, that's the Trust, and then the Trust do, we do within the budget, and it's we just go round and round in circles. So if there was somebody that has some responsibility from a departmental, and we've got department with Public Health Agency and Trust, and then it's not going to be one pitching off against another whenever we ask questions.
No, I think that's fair enough, and similar to the way the meeting was last week, we had, I know I wasn't here, but I did watch some of it back, the department, the Trust and that as well, so I think that would be useful. Linda?
Just to make a quick point, I think it is definitely worth having departmental officials involved in this conversation, because a couple of things we need to understand. How is the new HPV testing working? And maybe, I would imagine we're a year into that, so I would like to get an understanding of that. But also, and this is the case in so many things around women's health, we've raised it repeatedly in this committee, but why the delay in actually introducing HPV testing? And the current minister wasn't in place. I agree with Colin in saying that, but his colleague was. And I want to understand why that HPV testing was not put in place sooner, because it was only after this happened. And I met with Peter May in relation to the Assembly wasn't sitting at the time. I met with the Permanent Secretary in relation to this. And it was at that point then they decided they were going to move to HPV testing. But frankly, I think it was a money-saving exercise. And that is the case in everything to do with women's health, as far as I can see. So I think Colin's point is actually well made. We do need to have at the very least the departmental officials, but that was a ministerial decision.
Okay, thank you for that, Linda. Okay, so we'll get that organised as quickly as possible then, members. Thank you. Members, the other thing was just the visit to the Northern Ireland Hospice last Thursday morning. Members visited the hospice part of the committee's inquiry into access and palliative care services. And I just want to thank the hospice staff for taking the time to brief members on the services they provide. And I'm really sorry I wasn't able to be there for that as well. And the visits, the committee visits into the hospices and other services will continue in the new year, including a rescheduled visit to the Children's Hospice as that didn't go ahead last week as planned. Diane?
No, just to say I was at the hospice, and I know that sometimes just things happen that you just can't get, so that's fine. But it was one of the most worthwhile visits that I have done. I met some of the patients, I met some of the palliative care consultants, and the sense of relief of the patients who were able to live pain-free and who their quality of life had improved. And it was just, it was an uplifting experience. Mm-hmm. And I just wanted to put that in the record. I really was the better for having been to the hospice and seen the absolutely fantastic things that they can do to help people. In very, very vulnerable people in difficult circumstances.
No, I would concur. I've been down with them as well. Danny and I both were down with the hospice a few months back, and I've been in the Children's Hospice a few times, and it is another fabulous. It's a lovely experience too going down. So I think everything you've said there is so on point. But yeah, so hopefully we can get more people to the rest of the visits as well. Okay, members, the draft minutes then are at page 6 of your pack from last week's meeting. So just our members are content to agree the minutes as drafted.
Mm-hmm. I raise an issue. It's not really to do with the minutes, but it's to do, I can't see it in the minute whether, or maybe it's at a later point where the Belfast Trust tabled a correction to their evidence at the meeting.
So it's in matters arising. Sorry, I'll cover it now, and I can cover it in this.
Oh right, well then I'll wait.
Sorry, yeah.
No,
sorry, no, that was my fault. So yes, if members are happy with the minutes, then I'll move on then. So matters arising, just I'll refer you to the correspondence from the Belfast Trust at page 16, which was highlighting an error in the information given during last week's briefing on the new maternity hospital. The Trust have provided a revised briefing paper at page 25 of your table papers. And the interim Belfast Trust Chief Executive stated at the briefing that her predecessor had accepted the handover in March 2024. The Chief Executive has now corrected this to state that she had accepted the billing on behalf of the Trust. So Diane, do you want to come in on that?
I do want to come in on that because I do think it is quite an incredible statement that the Acting Chief Executive of the Belfast Trust has now given evidence twice on this particular issue to this committee. And not once did she actually say that I was the person that accepted the handover. Now, I'm absolutely willing to accept that it was done on the advice of a range of people and so on. I'm absolutely willing to accept that. But I do think it is quite incredible that we were not told that. Even when I questioned her at the end as the responsible officer, did she believe that the building was safe at handover? And even then, she did not say that she was the person that took the handover. And I think I think this committee should take that very seriously. And that is something that we should not allow people to come to this scrutiny committee and not give us the information that we need to do proper scrutiny. It wasn't in the written paper that was briefed to the committee, and it wasn't in the evidence. In fact, something to the contrary was in the evidence. And I think this committee should take that seriously. And I think that the second element of this that upsets me greatly and grieves me is that we had the Deputy Permanent Secretary from the department here who would also have known who was the responsible officer and responsible for the handover of the building, and he didn't correct the evidence either in the evidence session. I think that is really quite reprehensible and actually does not give the committee the respect that it should have, and that this committee should take it seriously. And I don't know what the committee can do, but I do think that this committee should take that extremely seriously.
Thank you, Dan, Colin, and then Danny. Sorry.
All I can say is it's an honest response that when we had the conversation afterwards, and I had kind of suggested it was a pity we didn't have the person that was responsible for the project with us, and then I was informed that actually the interim chief executive was, and the fact that I didn't know that and that wasn't presented in any shape or form, it did make my jaw kind of hit the ground a wee bit. And I mean, we were talking about a process, we were trying to interrogate a process because we felt that there may have been omissions, things may have been overlooked, things may not have been checked properly, and we wanted to get to understand that. And to leave that bit of information out that the sign over was actually done by the person presenting, but to say somebody else was quite an omission and quite an overlook. And I take at face value the email that comes in that says it wasn't intentional, and that's grand, but it just kind of, I think, spoke to what we actually were having the entire session for, which was about a process that felt like things, that T's weren't being crossed and I's weren't being dotted, and that was a major I that wasn't dotted, to say that it was a different person that signed over the project just 6 months ago, when in fact it was you, the person that was presenting, that signed over the bill. And it left me feeling very uncomfortable, and makes me reiterate my position that I do not feel that the Belfast Trust can be trusted to actually deliver these projects, and the department really needs to get involved.
I did last week put down a priority written question asking the Minister, did he believe that the Belfast Trust should be in special measures? The Minister has chosen not to answer that priority written question as yet, unless it comes in today, but it is overdue. But I do think that we are about to embark on a new children's hospital. Whatever has happened with the maternity, and I don't think we've completely seen the end of that one, and we're about to embark on a new children's hospital, which has easily doubled in price, maybe more than doubled in price. And I would not like to think that some future committee of the Health Committee, some scrutiny committee, would be actually doing exactly the same thing. And I think it is reprehensible that we were not informed, and that the person given the evidence spoke in the third party about the handover but didn't say actually it was me, and then waited to 10 to 4 on Friday to issue a correction. I think that is reprehensible.
Danny?
I agree. It is an incredibly shocking thing to see. Whether, obviously, they're saying that it was done in error, but it's quite a huge, shocking omission. What I would like to see is, do we know? Obviously, it says in the correction that there were it was taken under advice. Do we know the range of that advice, and do we know if there was any dissenting voices within that advice? Would it be possible to write and ask for that advice so that we could be aware of any possible dissension within the advice that was given at the time?
Ask. We can find that out. Okay, members.
As a committee, can we at the very minimum write to the Minister to express our view on this particular issue and ask what he is going to do to make sure the Trust live up to the responsibility? If ever there was a need for a duty of candour, I think we've just demonstrated it.
We can do that. Thank you. Okay then, members, we move on then to our first briefing, which is the oral briefing on the waiting lists. If I can refer you to page 18 of your pack, which includes a written briefing from the department providing a very high level update regarding waiting lists. So hello Thomas, you're all very welcome back. So in attendance today we have Lisa McWilliams, Director of Performance, Strategic Planning and Performance Group, Dr Tomas Adele, Director of Elective Care and Cancer Policy, Joanna Elliott, Head of Elective Care Policy, and Katrina O'Connor, also Head of Elective Care Policy. So thank you all. And I know, Tomas, you may need to leave around 3.
Yes, and I think we all need to leave at 3.
Everybody needs to go at 3, okay. So if we can keep the opening remarks then as brief as possible, and then we can open up for questions, if that's okay.
Yes, and I believe the opening remark was shared with you by accident. So hopefully
We've already read them.
Do not show to the defence.
I'll keep myself very short here. So first of all, thank you very much for having us here today, and thank you for having us first on agenda. So you know who we are. It's great to be here again. So we shared a briefing paper and my opening remarks, and hopefully you found that helpful. There are just 4 things I want to address very quickly, and the first is the concept of Big Bang in elective care. You want us to sit here and say, if you do this one thing, we'll solve waiting list. And I just want to be really clear that there is no such one big thing we can do. The big transformation in waiting list and elective care is elective care centres. It is creating various levels of day procedure, elective overnight and complex elective care centres, and fundamentally the structural change required for that has essentially been done. We have day procedure centres, we have elective care elective overnight stay centres, and we have a complex centre in the city hospital. This is really good work, and it presents good news stories of what's happening. In interest of time, I'm not going to go through where exactly they are and what's happened, but you know roughly what's happening. This is the big reform. This works in other jurisdictions, and we know it works here when it's working well. That doesn't mean there's not more to be done in those, but the big changes have been done. On top of that, we need to do everyday reform, and that is to make sure these centres work well and that each speciality operates as effective as possible across the spectrum, that pathways are as perfect as they can be. These are all really important work. That's hard grinding work that takes significant time. In themselves, they're not going to create massive change, but many things, small things added together, creates big difference. So we have completed reviews of gender review general surgeries. We set standards for surgery that's applicable across surgical specialities. We do getting right first times reviews of a number of specialities. There's outpatient modernization to look at how we can do outpatients better. This is happening across many areas. This work is hugely important. This is really the core of what we are focusing on at the moment, to make sure things are working and make sure things are working well and as optimal as possible. In this work, there will need to be difficult decisions made. And I think it's really important to highlight that. We will need to move things into day case, into treatment room, that the tradition has been patients staying overnight. There is a cultural shift for our patient population. Many patients assume that when you have elective surgery, you stay in hospital overnight, that is the best outcome. The reality is that the best for the patient is to go home as soon as possible. So this is not just for efficiency, which it also is. It is actually because it's better for patients. And it's also much more efficient for the system. So others, for example, patient-initiated follow-up, that means that patients might not be asked to come back to a consultant after surgery, but instead been given contact information on how to contact the system if they need to. This is better for patients. It works. It avoids patients traveling to hospitals unnecessarily. It works really well across cancer services. So most cancer patients are not asked to come back for regular checkup, regular checkup, but instead asked to contact the system if something is wrong. That is a big culture shift that we need to go through as well. There will also be want to reconfigure how services are delivered. This is not about closing things, but say that we want to move one specialty from one hospital to another to make sure it's more efficient and provide better patient outcomes. That is something we will obviously do with you and with the wider public, but it's something that's really important that we look at how we get that right. So we don't expect everywhere to do everything, but instead we can specialize in certain areas. So one hospital becomes really good at something, another hospital becomes really good at something else. That's better for patients because the staff do it all the time, and it's better for efficiency because the system works better that way. That is not something we can do together. That is something we need your help with as members here. That's something we need the public's help with. I'm not saying you shouldn't challenge us, please do, but we have to accept that it can't just be a no, there has to be a want to change in that. Those are difficult things to do, and there's other things as well. And we certainly hope for your support when we come with proposals for that going forward, after robust challenges, of course. I'm not asking you to challenge us. I also want to address the huge backlog of patients we have, because we have two problems. We have a demand capacity problem, we have a backlog problem. The backlog is huge. The numbers are completely unacceptable. This is not a new problem. This problem has gone on since 2010, really, if you look at our statistics, bar a short exception in 2013. Fixing something that has been happening for many, many years takes time. We cannot fix the huge backlog quickly. It is simply impossible. We estimate that it can be done in 5 years if we have huge investment. But we just want to make it very clear, this is not an easy fix. When it comes to investments, we have a significant demand capacity gap. In elective care services outside cancer and time critical, we estimate there is about 80 million pounds a year demand capacity gap just to deal with the demand. I mean, so that's when you increase that capacity. That is after the efficiency work we're doing currently. So if we do the efficiencies, we still have a significant gap. So even if we fix the backlog, but if we don't fix the demand capacity gap, we will just keep adding more patients on. As I said, we need to fix the backlog. We estimate it will cost up to 135 million pounds per year for up to 5 years. Obviously, the numbers are very, very big, so there will be variations as if we were getting funding to go through that, and hopefully with everything we can reduce that cost. But that's our estimation based on who we have on the waiting lists. These are very significant investment requirements in a very challenging context, but that is the reality. We can't do this by just efficiencies or by just doing things better. We need to invest to fix these things, or obviously stop demand by changing who we treat and changing those things. That's really the options we have available to us. That has been a very quick tour of my opening remarks, so thank you very much. We're happy to take any questions.
Thank you, Tomas. I suppose, and we have had an informal session as well, which we have taken some of this out. I mean, certainly from reading the briefing, the figures around the breast cancer waiting times are absolutely shocking, which you'll not be surprised that I've raised that. And I just wanted to speak to that first, if that's okay. I suppose looking at, I mean, and I have had this conversation just today with a GP, and it's probably, I know the Minister announced the regional service, so I would be keen to hear where that's at. I mean, in the figures here for the 14-day target, they're getting increasingly worse for every trust. When you look at it right across that table, and I think at present the average number of people who are being seen by that target is just under 31%, which is an urgent referral. But the figures that really confused me, or I suppose confused isn't the right word, have really shocked me, is the difference in Belfast Trust. So in September 2023, 95.6% of people who had received an urgent referral after being seen by a breast cancer specialist were seen within that target. 3 months later, only 25.1% of those people were being seen, and that's got continually worse. March 20.4 was 20.4. I know we don't have the figures for June because of the rollout of Encompass. Is there any explanation why there's such a jump from 95.6 to 25.1 in those 3 months? So there are a number of reasons for this. And one thing, the first thing to remember is the 14-day target is a black and white target. So if someone is seen on day 14 or 13, they're in the target. If seen on day 15, they're out. So even a small shift. So if patients seen quite often at 10, 11, 12 days, a small shift in capacity or small change will push everyone above the target. In that period, South Eastern Trust went live with Encompass. So the South Eastern Trust capacity was significantly reduced, and patients and Belfast Trust taking South Eastern Trust patients. That's one big reason. Then there are all the services, whether it's regionalising, are very small. So there's small number of staff, small number of consultants in each trust. So if one consultant is not available for whatever reason, sick leave, maternity leave, annual leave, the service struggles straight away. So they can be very small changes that has a big impact on these numbers, whereas the total difference is not necessarily that big. Looking at Belfast, how long people are waiting. So let's figure out from beginning of November for people who do not have an appointment yet. Most patients are less than 14 days waiting. There are some patients 15 and 21, and some between 22 and 28 days, and no one beyond 35 days. That is better than it was a year ago. So it's improving, but it's not as good as it should be. Yeah. No, and I appreciate it. It's just to get an understanding, because when you look at all those figures, that is a huge jump in a very, very short space of time. And I know Encompass will have had an impact, but it hasn't. It's actually continuing to decrease. So I think it's just something that really, really shocked me. And I mean, then we look at the Western Trust, which yes is gradually worsening, but they're still, and during this year, they still were able to meet their target by 82.6%. So have we an idea of why they're doing so well in comparison to other trust areas?
So I mean, Western Trust are doing remarkably well. The latest stats have this: no one waiting more than 7 days. One reason is they have a very, very stable workforce, and the workforce is willing to do extra hours and to work to accommodate all patients they have. That means that they can, because of stability of the workforce, they can see the patient they should be seeing. So if you're looking at a whole region over a year, we have about 16,000 referrals in breast, and the system deals with about 16,000 patients. So over the space of 12 months, we don't have an increase, but it goes up and down in different places. Western trusts are really stable, so therefore they're always really stable. The other trusts are all fluctuating up and down. And that's why we want to regionalize the service, to make sure that we have same weights across everywhere. So wherever you're from, you have the same access service. In the beginning of that work, we expect the 14-day target to get lower, to get worse, because everyone will have to wait a little bit longer. So Western Trust will get worse because they will be equalized waits. But instead of some people waiting 7, 8, 9, 10 weeks, everyone might be waiting 3-4 weeks, if that makes sense. That is because we're equalizing those waits.
So the regional service then that the Minister announced, where are we at with that? And do you think then, I mean, if when we see such a difference across trusts, I know generally that the other 4 trusts are all pretty low. Do you feel that that would help to introduce a more equal access and a more that there would be greater equity in capacity then that people can access given the demand?
So the initial phase, which is the single waiting list, which will go live for Belfast Northern and South Eastern first, because they have one data system. That means the patients will be allocated a space where the next available slot is. Obviously with common sense to place people as close to home as possible, if that is possible. But it means the wait should be equal across those trusts. Southern will come live very, very soon after. Western Trust, because they don't have a backlog at the moment, they will probably wait until after, or they will wait until after Epic goes live in May next year.
When is the Belfast Northern and South Eastern going live?
In the next few months. I don't want to give an exact date, I can't do that, but...
And then Southern is May, did you say?
No, Southern soon after is
so
the plan.
Western's May?
Western is May. Western, because they don't have backlog,
okay.
It's not a immediate concern in the same way.
Yeah.
That other trust, we want to make sure that we equalise weights very, very quickly. And I mean, what worries me most is not the 14-day target, and that worries me, but it's a really long waiters. So in reality, if someone waiting 2 weeks or 3 weeks, it will not have a great impact on a clinical outcome. Someone waiting 8, 9, 10, 11 weeks, that will, or they can, should we say. And I mean, in Southern Trust, there are people waiting over 42 days to have an appointment. There are people in Northern Trust waiting more than 36 days for an appointment. That is what we need to fix. That's a priority to fix those things. If people wait 13 days or 16 days, that's we want to be 13 days, don't get me wrong, we want to be sure this is possible, but the first bit has to be the really long waiters.
Yeah. Okay, no, thank you for that, Tomas. I suppose just in terms of the funding that's needed, that's outlined there, I think if you tie it all together, it's approximately 291 million, and that's including the 76 for this year. I mean, how confident are you that that could be achieved? I mean, I suppose the reason I'm asking that is, if we were able to tackle waiting lists, the pressure elsewhere would be relieved. Okay, and I know you know that, and I'm not. I suppose so. I mean, is that being emphasised in the broader conversation within the department to say, look, if we can allocate this within our budget, maybe in subsequent bids going forward, and we can allocate that within our budget, that may impact in other areas in the short term, but it actually will have a benefit, because I'm meeting with GPs and they're telling me that people are coming in, and we know this, we've had these conversations here, maybe sitting on a waiting list for a hip or a knee or whatever it may be, chronic pain, and they're in their GP constantly, and that's a huge pressure, or they're maybe in A&E, depending on what it is. So it's trying to balance that out. So is that part of the conversation to say, well, listen, if we don't do this, we're going to need more money in the budget over here, or can we take the risk and allocate more into the waiting list initiatives that have been outlined here that will have a timely benefit, so that, you understand what I'm asking?
Absolutely, and I mean that's very much part of the discussion. I mean, we know from research in other jurisdictions that someone on the waiting list goes to GPs somewhere to once every month, once every 2 months. And if you're talking a few 100,000 or quite a few 100,000 people, that's quite a lot of GP visits, as an example. It's the same with ED attendances and so on. That's something we're highlighting and showing the pressures, financial pressures across the system are huge too. Yeah. Their difficulties. It's hard to take money off unscheduled care when people are standing in the
absolutely, yeah.
And it's
and I'm not suggesting that, by the way.
I mean, that's difficult, and one of the problems we have, and I'm right when I say problems, is that this kind of care is very expensive. So I mean, secondary care, theatres is some of the most expensive things we do. Yeah. So to get the levels we need, a lot of other stuff would have to stop. Yeah. It's not. I mean, other way around would have been easier, if you know, in terms of financial equalisation.
Yeah, no, I get that. And I suppose I was just trying to understand how it's worked out that, you know, for me, I think if we could get a real good grip of the waiting lists, we would see the benefits right across. I'm only going to ask one more question because it ties in with that, and it is around that waiting well. I mean, what work has been done for patients who are long waiters to help them to wait well? It's a huge issue, given that it then puts pressure on other aspects of the health service. I've recently met with Versus Arthritis and on organisations like that who are very vocal in relation to this, and rightly so. But I mean, I think it's that broader impact on people who, and I'm going back to orthopaedics as an example, people who are waiting on a surgery, so they are out of the workforce for that period of time, because they're not always people who are retired or anything like that. Their quality of lives are impacted, all of those things, which has a broader impact, not just in terms of our health service, but on the economy and our communities and all as well. So it'd be good to get a wee bit of understanding of what work's being done around that.
So we have a team within the department who are currently working on the development of a waiting well policy. You've mentioned Burst Arthritis there. We're very much engaged with them and the Long-Term Conditions Alliance. We've met and we've engaged with Wales actually. Our Welsh counterparts have a policy, the 3 Ps, which is about promoting healthy behaviours, preventing decondition and whilst waiting, and preparing for treatment and recovery. So we're very much in that space where we recognise that the biggest problem is the waiting list and trying to, reduce those. But the reality of it is that people will wait, and while they wait, they will have potentially to deteriorate and things like that. We need to support them. We need to signpost them to where they can get support where they need it, and the likes of even rehabilitation, or just knowing what charities there are out there to help them. We've actually funded a pilot locally in the Western Trust very recently to test this concept. It's about looking at patients on orthopaedic waiting lists and directing them to things like walking groups or things like that, which will help them to stay active. It is a huge issue, but it's one that we really recognise the need to do. So we're working on that at the minute, and we really are hopeful to have a policy drafted sometime within the next 6 months, which we will then take to public consultation.
Okay, no, thank you, Katrina. I suppose you've just reminded me of one quick thing, but it came up when we met with the trusts in relation to the amount of people that didn't attend appointments. And it has sparked a real conversation in terms of what are we doing to tackle that. So that's my next question, because I think I've learned even from that meeting that there are methods in place across the water and in other areas that are trying to do that using AI and other technologies. I mean, is there a focus on looking at why people aren't attending? I know that people get calls the day before and all of those things, but there's still a reason why people don't attend, and it's trying to make sure that we're not losing that, and also if there are issues, helping people to get to appointments. So is there a particular emphasis in relation to that?
Yeah, and if I can respond to that. So at the moment, if an individual does not attend either an assessment or a treatment appointment, there's no current mechanism of actually capturing that individual's feedback for the reason why they didn't attend. So therefore, trusts have done very small scale audits, which have found, and I suppose some of the questions have been, was travelling to one of our new elective centres an issue, and the Western Trust audit, by case in point, would say no, travel's not an issue. But actually there's no systemic way of capturing that information. So we have asked the waiting list management unit to actually audit a cohort of the do not attends for Lagan Valley. So we're currently working with South Eastern Trust to get the data access agreement where we will reach out to those individuals. We need them to engage with us when we reach out to actually try and understand why they didn't attend. And the reason for doing that is because it may be that we hadn't given the right information to them, or they had no way of contacting us if an issue had arisen. So actually we'll use that audit to actually change some of the communication. We need to kind of understand if it's a value. Is the appointment valued? And if someone's waited a very long time, you could assume it doesn't have this, they could just wait longer. Is that an issue? Because if that is, then we need to be very clear it's not a free good. It's stopping somebody else having access to that slot. But we need to understand, we actually need to speak to the individuals to actually try and capture that, and then we will target, and the other, there is something about indicating how much those slots are maybe being, how many of them are and what the cost is to the public. So we really need to target communications. Now, we do know that pre-op assessment is one of our challenges for our cancellation level. So we are also working on pre-op assessment across the region to see if we can make that better. So if someone's been on a waiting list for a very long time, we need to make sure that pre-op assessment is correct so that they're still being signposted to the right location and that their condition hasn't changed dramatically, therefore they wouldn't be suitable for the procedure, or they need a procedure that maybe moves from day case to an inpatient. So we're already doing work in that area, but we will be commencing that audit in January.
Yeah, I think it's critical, given now if we're trying to increase our capacity and get through the waiting lists, and people, there's slots, or if someone got a phone call the day before and would, could easily take it up if that was the case. But understanding why it's possible. Look, I'm not going to go on anymore. I could, but I'm not. I know we're very limited for time. Colin, so thank you for that, Colin.
Thank you, Chair, and thank you very much for your opening remarks, not least getting them 4 days in advance was very useful. But just in the remarks that you made there, I don't know whether you actually said them or it's in there, there's this reference to a 20% reduction in weights that we have. Now, the Minister also mentioned the 20% reduction in weights in his speech on Monday, but then went on to say that taking into account the data available for Belfast and South Eastern Trust, this represented a decrease of 5.5% in the numbers waiting. So is it 20% or 5.5, or is it 20% for some and 5.5 for others?
So if you hadn't seen that document, it would have said 14%, because that's it depends how you count. But if you're looking at treatment weights since the peak in 2022, compared to the latest stats we have for all trusts, with the knowledge that the Encompass data is not necessarily as safe as we want it to be, it is a 14% reduction. So it's and that is a 14% reduction in that period. And obviously that's one reason why the doc wasn't meant to be shared with you, because the numbers hadn't been fact checked. So please accept it.
Fine. And it kind of leads into just the next point then, which is like, for us certainly to carry out our scrutiny role, data is really important, and I'm beginning to worry that we're hiding a little bit behind Encompass in terms of not being able to give accurate figures or up-to-date figures. And it's the South Eastern Trust and Belfast Trust at the minute, but we're very quickly going to have the rest of Northern Ireland online in terms of Encompass, and I feel that we're going to stray very quickly next year into a phase where the figures that are being presented are just not going to be accurate and they're not going to tell us something. So from your perspective in terms of the waiting list, why is it that Encompass can't? I mean, it's supposed to be all singing, all dancing, and I would suspect that the words all singing and all dancing were probably used whenever the business case was being put together to spend tens if not hundreds of millions of pounds on it. Why can it not tell us what waiting times are and how long people are waiting? And
there are many answers here, and Lisa can take some of them, but one thing is that we need to make sure we measure exactly the same things. So when do we start count something, when do we not count something, what do we count, what do we not count? Different systems at the starting point is different because things are coded differently. That's one reason why it's difficult to compare data straight across. Data for South Eastern and Belfast are published, but with the caveat that there might be inaccuracies, or sorry, they're not as confident as we are, saying that our numbers are so big in the first place when it comes to waiting list, that if we, not sounding so flippant, but if we're a little bit off, it doesn't change the scale of the problem that much. The scale of the problem is still completely unacceptable. Does that make sense?
yeah, sure, fair enough.
And there is a difference between the data, which is the official statistics, which needs to meet the industry guidelines, but the trusts and certainly Strategic Planning Performance Group, we have management information. So we have a level of information where we are seeing the trends, and we still use that. So we're looking at that. Scopes is a good example. You'd mentioned the reduction in waiting times. Scopes are now back to their March 2020 level of waits, which is a 35% reduction. We had a big peak after COVID because of Scopes was one of the areas with with concerns about COVID that actually had a massive rise, but actually we can see, so it's reduced by nearly 14,000. So we can see that through management information, which maybe wouldn't meet the industry standards for official statistics. So there is still information available. With Encompass, with any new system, as Tomas has indicated, whenever we're first pulling reports, it is checking, has something changed? Is this have we changed the way that we set up a service? Are we counting the same inpatients that we were counting before? And that has been a real challenge because that isn't necessarily a direct read across. And then, there is an embedding period. So the Northern Trust is our most recent trust that's gone live, and they're working through that process of understanding, are there workforce challenges? Is the system being used correctly? So we'll have that for every trust that goes live. So the next 2 trusts go live at the same time in March. So there is an acknowledgement that they'll go through a similar, verification process where the I suppose the official statistics will take a bit of time to have the conditions and the caveats removed, but that doesn't stop management information, which trusts will be using at service level, and we certainly have access to that from a performance and a planning.
Absolutely. In terms of performance and then accountability, we need those figures, and we can't just continually go to, Encompasses there, it's skewing it. So I hope that gets settled soon. Just a final question. Again, in terms of waiting times, our staff, our health service staff, we rely upon them. They are worked to the bone. Many of them are stressed. Many of them are approaching burnout. They're covering extra shifts, they're covering extra hours, and we still aren't even at a stage where we can confirm that we can pay them the same amount as the other professionals across the UK. But yet on Monday, from the department and the minister, we're told that you're going to get them to do another 57,000 health service initiatives by just working harder. How can we ask our staff to work harder than they're working at the minute, not guarantee them the right level of pay, and they're already through all of the agencies telling us that they just can do no more? How is it possible to come up with 57,000 extra?
So there's a couple of things. First of all, I think we all want to acknowledge that our health service staff work really hard. There's no questions about that. I must declare an interest. My wife's a nurse.
If you get up in the morning and tell her to work harder for the day, you'll be in trouble.
And the key thing is that it's not about asking individual staff to work harder. It's about getting the systems to work better, so the staff can do what they're best at. That's a shift. So it's not the staff, it's a system. They need to work better, if that makes sense. We need to enable staff to do what they're good at. And that's essentially management and our issue, not the staff's issue. Yeah. Sorry.
So it is part of, because we have alluded to the efficiency and productivity drive. So the calculations that have been done have been looking at if we were at our theatre utilisation, the optimum amounts, so we're not quite there in some areas. If we use all of our tools to address the DNAs, if we tighten up the hospital controllable cancellations, so they are all the calculations that lead to that. So it's not about longer days without being paid for it. It's not about doing weekend or evening lists without being paid for it. It is, as Tomas says, if the system actually complied with the protocols that we have for people who are who maybe have not attended for a number of appointments, instead of being discharged, keeping those individuals on, actually that's not good for the system, and actually is using slots that others could use. So actually that additional is that efficiency and productivity being put in, being modelled up against benchmarks where we know that we have areas to move. So so we have a full calculation behind it to actually say if we were doing, and it assumes we don't have any significant loss in workforce over the next 3 years, but actually just driving that efficiency and productivity. So the system helping the teams, having the right focus, clinical teams being supported throughout their organisation, and having that, focus on, can we be sure that we have best value for money because of the resource that we have? Can we be sure that we're using it? So it's not about doing more, in terms of extra hours without pay. It's about being really, really strong with our processes.
I still contend that the 57,000 extra interventions will have to be carried out by doctors and nurses and healthcare professionals, so they will be doing stuff that they previously wouldn't have been doing, so that's 57,000.
But some of that is about getting back to our pre-COVID levels, which we're not at, so they were previously doing that. So it is going back to some of those levels.
And anything, so theatre staff, they want to operate. That's what they're there for. That's what they enjoy doing. If 1 in 10 patients don't turn up, they stand in theatres ready to operate but don't have a patient. Yeah. If we as a system can reduce DNAs, they will have a patient. That's what they want to do. Yeah. They don't want to stand around and do nothing. And it's those things. So it's not asking more about staff. It's about making sure the staff get the opportunity to do what they want to do.
Some of the next questions might be from a healthcare practicing official who may tell you that not many people are standing around doing very little, but we'll pass on. Thank you, Chair.
Yeah, I'm conscious there's less than 10 minutes left before the officials need to leave, so I've got Alan Robinson, Diane and then Danny, if we just keep that in mind. But if there's any questions that we don't get through, we can follow up with writing if that's okay. So Alan.
Thank you, Chair, and thank you, team, for giving us the overview today. I'm not sure any of us will be leaving today with a spring in our step, given the detail within the first few paragraphs, where again you're requiring, on top of the 76 million, you require 80 million recurrent funding and 135 non-recurrent. And I suppose within your report, we're grasping on to any good news that we can get within the report. And I noticed in one of the paragraphs there was reference made to shared island funding. Could you give us some information on that? I know it specifically referred to a number of high-profile cancer projects. Could you give us just a wee bit of detail on that? But also just ask, just on the back of what Liz had been referring to, but waiting list, or those who did not arrive. I assume the increase in traffic congestion in Belfast is also adding to the numbers that are not getting to the main hospitals in Belfast. And is that data being captured, is it?
On the shared island funding, I have to come back to in writing in details. There is work with among officials in cancer for cross-border work, and it's been going for a long time. And there is discussion on shared island funding, what we can do to enhance the cross-border work. So the North West Cancer Centre takes patients both the south and north, for example. And we had a number of meetings with officials from the south on those issues. But for details, I have to come back to you in writing.
And on the specific point about traffic congestion and the impact on do not attends, and I suppose we'll have to pick it up with Belfast. I don't think that they've done an audit to capture that, but I think traffic congestion is more likely to show individuals turning up late for appointments, as opposed to not attending, and where possible, clinics and even theatres will move around to try and accommodate that. But and we can certainly. Some of the Lagan Valley audit might be patients that are having to travel through Belfast to get to Lagan Valley, so it might be picked up in that audit, but I wouldn't have any evidence at this stage that congestion's played a part in that.
Alan, is that you? Yep, thank you. Diane?
Thank you. So, a number of things. In terms of the cancer waiting lists, the figures that you quote are figures up to June of this year, June 24. I quoted those statistics in a debate on cancer waiting times in the Southern Trust in October. I received a letter from the Minister on the 29th of October, which went through some of the issues that I had raised on those very statistics. And he said that they had plans to reduce immediate pressures by transferring people to other trusts with additional clinics and mega clinics. I understand that the South Eastern Trust at least have convened mega clinics. Why did you wait so long to convene the mega clinics? And why did we have to have that level of scrutiny for those mega clinics to actually happen when you knew that the cancer waiting lists were this bad in June 24?
The mega clinics, cancers and moving patients around is not a new thing. That's been ongoing for a very long time.
But I since the letter of the 29th of October, some of those mega clinics have happened.
Oh, absolutely. I mean, Southern Trust, if we took breast patients, in April there were, on a very rough calculation, 200 patients waiting more than 4 weeks for an assessment. In beginning of November, that same figure is about 30.
Yeah, because they'd had the clinics in between time. But why? My question really, Thomas, and I don't want to actually focus on this because I have a couple of other questions I want to ask you. But why does it take that level of scrutiny before we get to the mega clinics and so on? You knew this was happening. These are figures from June. These are actually now old figures. They're almost 6 months out of date now. I'm hoping that when we see the figures in a short period of time, those figures will have improved dramatically. But it always seems to me that it always takes a bit of a push and a hue and cry to actually make the thing move. And I think that is really bad. And I'm going to just talk about women's health for women's health. And why do we do that? We have the example this week of the Southern Trust and the issue of women's health. We have the example of breast cancer policy. I'd really like to know an answer, but I don't want to focus on that actually today. I have a couple of other questions that I do want to ask.
So very, very quickly, I mean, these clinics, I mean, I could take breast for example, they're not happening just after correspondence or just after stats. They're happening where the need is the most. So earlier on this year, so in January, February time, there was Southeastern Trust, because that were the longest waits were. So patients moved from Southeastern Trust.
Maybe just to shorten this element, because I don't want to keep you beyond 3. Maybe somebody will write to us about that.
Yeah,
tell us what mega clinics happened, why they happened, what the stats were that triggered those mega clinics, etc., etc. I just find that would be very, very useful.
Just to clarify, do you want to focus on breast as an example, or do you want wider?
Well, even if we focus on breast at this, because those are the stats that you gave in the presentation, that would be very useful. Just to let us know where we start. In terms of elective care centres, and you say that elective care centres are the way forward, and that's fine. You, along with the clinicians, make those judgments, and I'm content that that's the way forward. I have asked a number of questions about the elective care centres that we have. At what capacity are they operating? Could they operate at a greater capacity? If we had more, for example, I noticed that the Northern Trust want to make Coleraine an elective care centre. If we had more, how many more operations we would do, and how many more surgeons, theatre staff, etc., we would need to do that. So that's one question, and I'm happy if you even just write to me, because I know that you're running out of time. So and the other issue is around the issue of non-shows, patients who don't turn up for appointments. We had the chief executives of the trusts in here, and Lisa, I was just interested in something that you said, where the chief executive of the Western Trust said that people didn't show up for appointments because they couldn't afford to take time off work. Are you telling me that there is no particular data in relation to why patients don't show up, or that trusts haven't done that kind of data audit? Because I'm just then wondering, why is that anecdotal evidence that we were being presented with, or data-driven evidence?
And I think the trusts have all indicated, because we did speak to them after the evidence that was given, and the trusts have confirmed they only have small-scale audit information. And when we spoke with the Western Trust, they specifically identified that travel was not an issue, but that communication and pre-op assessment would have been an area that they were focusing on. So that is the information that
I'm wondering why we were then given that kind of information in the committee.
And I think there is some evidence nationally that
no, this specific to the Western Trust.
We can't comment on.
Again, I think that when people come to committee, they should have evidence that they can actually stand over.
on the elected care centres, they would probably have it right because there's a lot
No,
of
that's
we
fine.
have
I
mod-
accept
we have
that.
modelling for
Can I
that, so
just
it's
ask
numbers.
one last one on? I met children and parents 2 Mondays ago. A number of us met them, and they're all waiting for PEG insertion surgery. And these are children, probably some of the most vulnerable children that we have in our society. They are very likely to have complex medical needs, and PEG insertion surgery would really help them to start to thrive in a way that they can't. I think I would like us as a committee to have the information exactly on how many children are waiting for that surgery, how long those children are waiting, and whether there's a distinction, or you make a distinction between children who are waiting for the initial insertion surgery or those who need maybe a reciting of the one that they already have. I had a constituent with a young person whose PEG has around it has broken down badly, and they'll probably need, it recited. I'm probably not even expressing the proper clinical, but they can't get it done. That child's in pain, constant pain, live in fear of infection, etc., etc. I had a mum this week whose little boy has a bleeding condition, and her child pulled out their gastro tube, their nasal tube, and they went to the Royal, to Children's, and they were told that they couldn't get it in because there wasn't the correct staff to monitor his other conditions in order to put it in. I think that's an intolerable situation that we now have. We had a waiting list initiative in October around this, but I do want to see what we're doing about it and how we can resolve that issue. We should not be keeping these children in pain and on waiting lists for a very long time. Thanks, Chair.
Thank you, Dana. I'm so sorry. I know you're tight, for very, very tight, but if we can ask your question, if we can't respond now, do come back.
I had a couple of questions I will write to you, Thomas, and I'm sure you probably know what it is. It's about the gap of the decrease of the patients going down, and do we have a breakdown of the patients who have left our waiting list system entirely because of other reasons rather than them having the operation? Do we know how many patients have left the system to go privately? Because we know there's been a huge expanse of private medication in our private.
The simple answer is we don't know that.
Right, so we don't know. We know that there's a two-tier system in Northern Ireland that people are being driven to the independent sector, but we don't know how many of them have been on our waiting list and for how long.
Because we don't have information of what's happening in the private sector.
Excuse me.
So,
We're celebrating a decrease, but we don't know what's driving the decrease.
So we would have information on where waiting lists have been validated and the reason for patients coming off, but it wouldn't give us a quantification. It would probably say treated already, so it wouldn't necessarily break down, because it might be that they've come through an emergency department or they've been treated in another trust. It wouldn't specify whether that was IS. So we do have information, but we don't, and some of the IS would be, if it's not funded through our waiting list initiatives, is commercially sensitive, so we wouldn't have that. But we certainly have a breakdown of where our validation has removed individuals from a waiting list, and some pre-op assessment and those pre-op assessment mega clinics. Some patients are being removed because actually they have other competing conditions that actually are much more serious. That are currently being focused, or they might be an inpatient and then not going to be suited. So we would have a level of information, but we don't have they've been treated in the IS unless we've paid for it through the waiting list initiatives.
We don't know how many people on the waiting list are being driven into the independent sector effectively. Yeah. The other questions, do we know how many people are passing away on waiting lists? Because obviously would that count as part of that decline as well?
We certainly, I would need to check whether that's because we do have an automatic system of capturing deceased patients, so I'll double check what information that shows and whether we can give you that.
Okay, and if you wouldn't mind writing to us with those results.
Yeah.
Just on, and to follow on from what Diane was saying as well, just about the children with the PEG tubes. From what I understand, it's a 5-year waiting list. There's under 100 children on a 5-year waiting list for a procedure that takes about 15 minutes.
We
surely
have an action plan
there's
asking with the Belfast Trust to see the action, because there's been, Diane, you alluded to the waiting list initiative, but also work with other hospitals, Alder Hay and others. So we've asked Belfast Trust for an action plan already in that space because of the concerns and the concerns that we would have about those individuals waiting.
I appreciate there's probably other groups in similar situations, but this one is, it's children in pain.
Terrible.
So, yeah.
It is actually terrible.
Absolutely. Okay, Danny, is that you? Thank you, and sorry for that. Look, thank you. I know we are slightly over time, so apologies again, but we really do appreciate your time. And there probably will be some follow-up that maybe we didn't get to.
As I said, we're always happy to write to you or come back, to be honest.
Okay.
Somebody can write us on the issues I raised there. That would be great. Thank you.
Thank you all very much.
Have a nice Christmas.
Yes. Thank you, members, and for your diligence. Is that the right word? But yeah, I think there's quite a few things even coming out of the question in particular around the independent sector. I would like to understand more, because surely on medical records, if people have had a procedure done somewhere else, that has to be part of it, because if there's aftercare involved or something happens on the back of that, or they're not being seen anymore, surely somebody's asking why.
We should know how many people on waiting lists are being driven into the independent sector. You know, I know it's happening in my constituency. I'm sure it's happening across every place.
It's happening everywhere.
Yeah.
But if you're going to announce a drop in the number of patients on a waiting list, then we need to understand, is that real? Have they gone elsewhere? Have they given up? And how many have we actually treated?
Yeah. No, absolutely.
Without that breakdown, you don't understand.
We need to be able to have a very clear understanding of where their waiting list initiatives have been applied, they're having the impact, as in people are being seen. But if we're getting figures that are skewed in sense, and it's not a criticism of the officials that were here, but if it's not a clear picture of what that looks like, so is 100% of that drop patients who've been seen through our NHS services, fantastic. But if it's only 50% or 30% because others have gone elsewhere, or have indeed passed away, it'd be good to understand that. Al?
I mean, we can talk about this, and it is an issue. Do we, as a committee, have the authority to perhaps suggest or instruct trusts to start producing that sort of data? That we, as a committee, that's what we would like to see. So do we have that authority to request them?
Well, I think that's what we're asking. Is that is that information available?
Can we instruct them? Do we have that authority to instruct them that this is something the committee wants?
Can request it,
and we want this.
We can request it.
Yeah. So
and
then
if
I propose we do that.
Yeah, happy to accept that. I think, and if there's a reason why that can't be made available, then they can explain. Maybe under GDPR. But I suppose we're not asking for confidential information. It's more, is that being monitored properly? Because again, it goes back to the issue that I raised, and I think Diane raised as well, around the do not attends. If we don't understand why, then we can't do anything about it. So.
Can we also ask about the Encompass? Because Encompass is constantly being used as an excuse for the southeastern and Belfast, and we're in a couple of months' time we're just
Northern's going to be the same very shortly.
Stonewalled with we can't give you that because of Encompass, and it's like it's the super duper computer program, and if it can't do the counting, whenever people used to do the counting before, you have to wonder what all those. And I did an assembly question, like 100 million or hundreds of millions that have been spent on it, and now we can't even work out how long people are on waiting lists. It seems a bit.
Are we due to get another update on Encompass at any stage? No, we've done informal sessions.
Nothing scheduled yet.
No.
The other thing about Encompass that I do think is interesting, some clinicians have said to me, is the amount of additional time it takes them to actually operate the Encompass system. Now, whether that's because it's new and people are getting used to it, and that's fair enough, but I think there are questions around that, and whether it really suits the system that we have. It's kind of a ready off the shelf system, isn't it? Mm-hmm. And whether it really suits the system we have.
Yeah. Okay, thank you, members. Okay, then our next item is the oral briefing on children's social care services. If I could refer you to tab 6 of your pack, including the clerk's memo, page 115, and a written briefing from the department at page 127. You're all very welcome back. Thank you. So in attendance today we have Eilish McDaniels, Director of Family and Children's Policy, Department of Health, Maura Dargan, Director of Children's Services, Executive Director of Social Work, South Eastern Trust, Colin McCafferty, Executive Director of Children's Services and Executive Director of Social Work, Southern Trust, and Michael Burns, Office of Social Services and Department of Health. So we have about an hour for this session. If I could invite officials to make some brief opening remarks, and then we'll open up for questions. Okay.
I'm going to start, Chair, and then I'll hand over to Maura and to Colin.
Thank you.
So good afternoon, and thanks for a further opportunity to brief the committee on progress made in connection with the independent review of children's services and the associated reform programme. You've introduced the directors, so I'll not do that again. We provided the committee with a briefing paper in advance of today's meeting, and the paper sets out what is being done across all our areas of the reform programme and how that work relates to recommendations from the Children's Services Review. 27 of the 53 recommendations have now been formally assigned to the reform programme, and a further 7 are being taken forward by the department, including those which are workforce related. It's accepted that much, although not all, of ongoing work has not translated as yet into tangible benefits for children and families. This is partly because the review indicated what needs to be done, but it didn't specify how. And through the reform programme, we're determining how best to implement the review recommendations. In some cases, that involves gathering evidence about things that are currently done, identifying best practice here and elsewhere, and calculating costs. In terms of key developments, work is continuing in relation to the establishment of a multi-agency front door and introducing greater skills mix into our frontline social work teams. These different approaches are intended to deliver a better, more effective and efficient way of delivering services, and in so doing will address waiting lists. Over the last 2 years, we have fast-tracked more than 400 newly qualified social workers into trust employment, invested in 40 new social work training places, and today we're launching a new social care strategy, and that's happening as we speak. Detailed work is being undertaken in relation to how we pay foster carers, how we recruit them, and how we support them. New models of residential care are being explored, including multi-site children's homes and smaller 2 to 3 bedded children's homes. In October, the Minister announced investment of around £13 million per year in services for children with a disability. And work is continuing to address unnecessary bureaucracy in social work, on new fostering regulations and standards, to strengthen relationships between children's social care and the voluntary and community sector, including the youth sector, and to develop a new family support model for Northern Ireland. In response to Recommendation 53, we successfully hosted a conference in late November, which involved children, families and carers, and Professor Jones also attended the conference and spoke at it. Among other things, the conference created the opportunity to showcase excellent practice within trusts and challenged us to think about how we roll out that really good practice across all areas. The general mood of the conference was one of optimism, tempered with the realism that there is still much that remains to be done. Last month, the Minister also sought the views or support of his executive colleagues in those recommendations that are significant and cross-cutting, the establishment of a Children and Families ALB and the appointment of a Minister for Children and Families. There was little support for a Minister on the basis of the potential repercussions of an appointment, and there was no consensus on establishing an ALB. And the Health Minister has confirmed publicly that he remains supportive of an ALB and is currently considering his options. That's a very high-level account, Chair, of what we've done or have been doing over the course of the last 3 months, and I brought along a number of directors to give you a deeper sense of the work that they are leading, both in relation to tackling waiting lists and fostering. And with your agreement, the intention is to repeat that for other areas of the reform programme at future meetings. And at this point, I'll hand over to Maura.
Thanks, Eilish. Good afternoon, and thank you everybody for the opportunity to come and talk a wee bit about the waiting list work stream, which I co-chair with Catherine Cassidy from SPPG. Professor Jones found that there were a record high of more than 4,000 children on waiting lists for social care at the time of his review, and the work plan of the waiting list work stream is in response to that. So recommendations 16 and 24 were assigned to the work stream, which focus on bringing about the strategic change necessary to reset our social work offer to children and families, moving to a position whereby we offer earlier and more prolonged support, and by reducing the number of social workers that are involved in children's lives. The work of the work stream initially focused on understanding how each of the trusts configured their services, and there were subgroups of middle and senior managers from across Northern Ireland that have examined areas such as Gateway, the Family Support and Intervention Service, our Looked After Children teams, and our Children with Disability teams. They looked at and scoped the team makeup, their staffing levels, the demand, which included caseloads as well as numbers on waiting lists, and they audited the thresholds for access to services and the types and nature of the social work response that was provided across Northern Ireland. So that work provided a level of assurance in some of the areas. So for example, in Gateway, which is our front door, we found that the response to referrals was similar across Northern Ireland, and on the whole there were robust systems in place at the front door. There's more work to be done in that area, and they're progressing to streamline the front door processes as much as they can in order to reduce bureaucracy and prepare for the development of Encompass system for children's services. The work did, however, identify variances in how service areas operate and function across trusts, including some quite innovative approaches to service provision. So as a result, some trusts are assessing the impact and are taking forward changes in how teams are configured and the services they deliver. But this isn't an easy task. Each trust needs to ensure that there's no unintended consequences for other service areas, and they need to ensure that they don't create unmet needs somewhere else. Also need to consider the potential impact for our staff. The move to an arm's length body plus would provide the platform to support these changes more readily than our current configuration across 5 trusts. In the more recent reporting period, there are a number of highlights just to bring to your attention. The management of unallocated cases policy, which is about our governance arrangements really, and making sure that children who are waiting for a service are as safe as possible, continues to be developed, and it's almost complete. So it will be considered by the waiting list work stream in due course. A big area for us at the moment is the review of multi-agency front door models in children's services across the UK and internationally, and that's progressing really well. There has been a field visit to Camden, which provided an opportunity to consider their model in detail, and a further field trip involving multi-agency and multi-professional colleagues is planned into February, I think it's planned for. And that will allow an opportunity for interested parties in considering kind of possible opportunities and challenges in considering that type of an arrangement for Northern Ireland. We're continuing to review other models. There's many out there. Stockport is another area that we're particularly looking at. They have received really outstanding Ofsted reports, so we look at it in more detail. But all of this work, I suppose, will inform a very detailed options appraisal that will then be brought for consideration by the Reform Board. So the third area that's ongoing relates to the detailed plan of work, which is focused in around our Family Support and Intervention Service, and that's really just about looking at the team structures and that broader strategy of trying to get involved with families earlier and in a more prolonged supportive way. And finally, one of the key recommendations from the review was around introducing skill mix in order to provide more practical supportive assistance to families, and by so doing reducing some of the non-professional work from our professional social workers. So to this end, a new enhanced support role for frontline teams, a Children's Family Senior Support Officer, is currently being progressed through the normal Agenda for Change processes. We're engaged with the department to finalise the role, and we are developing a support and training framework to support this new role, so that when they come into the system, that they will be well supported and have training and development opportunities available to them. So I just want to finish by noting a thanks to the many staff who've been fully engaged and committed to this work. There's significant numbers of staff really involved in doing that. And whilst progress is steady, the landscape really remains quite challenging because we still manage vacancies and absent levels that continue to impact on our frontline teams, and some areas are facing greater challenge than others. This reduced capacity alongside the increased demand means that teams will need to continue to prioritise those most at risk and at need. So the targeting of families who be best served with an earlier, supportive and prolonged offer of help whilst challenging remains the goal of the waiting list workstream. And that's all I was going to say at this. I was going to pass on to Colin now to talk about fostering.
Thanks, Maura. I suppose just a couple of opening comments. First of all, I genuinely want to thank the committee for taking an interest in this really important element of our health and social care delivery, namely foster care. We have approximately 3,500 children in Northern Ireland living in substitute family care, either in trust foster carers, independent sector carers, or within kinship care. But I also want to acknowledge the role played by our social work staff, our support services, and indeed many other multi-agency staff across education, policing service, range of voluntary and community sector, all of whom we depend sorely on in relation to supporting foster families and looked after children. I want to make particular reference and to genuinely thank the 2,500 foster care families or foster care households across the region who we are almost wholly dependent on for caring in excess of 90% of the looked after children population in Northern Ireland. So I think it's really, really important to acknowledge the 24/7 selfless continued dedication of these foster care families. Maybe just to set a wee bit of a context for the committee, as with all elements, it's a service that is challenged at the moment. There have been a number of fairly unique circumstances, which I talked previously about, but we're in a situation of a continued upwards trajectory with regards to our looked after children. There's been a 40% increase in the child and care population over the last 10 years, and we have now just in Northern Ireland breached the 4,000 mark of children in full-time care. And again, that was quite clearly articulated in Professor Ray Jones' report, obviously is an issue of significant challenge and indeed risk with regards to how we manage services. Bringing it directly back to foster care, it's a sector that was significantly impacted on in the context of the COVID pandemic, in the sense that for very understandable reasons there wasn't as many people coming forward to become foster carers, and we're still in a phase of seeking to recover from that, and we have not got back into the same level of recruitment and approval that we would have had pre-COVID. And then you put that in the context of increasing numbers of children in the care system, so we are increasingly asking the same carers to do more and more for us, and it's important that we acknowledge that. So, under the auspices of the Reform Board, one of the work streams which I co-chair with a director colleague from SPPG is in relation to fostering, which is inclusive of as I said, is co-chaired with SPPG. The makeup of it is multi-agency and cross-sectoral, from representatives from trusts and other relevant stakeholders with regards to fostering. There are very clear links with foster carers in terms of engagement, getting information from them, testing ideas and so forth, and also with care experienced young people. So, in brief, there's a number of key priorities. Linking it directly to the Ray Jones report, it's linked to recommendation 26 and 27. 26, which is about improved recruitment processes and expanding the range of foster carers available. And recommendation 27 is about ensuring that our foster carers become valued, supported components of obviously the care system with regards to it. So I'll just briefly update the committee on the priorities from the work stream. Number one is reviewing a foster care service model across the region with the objective of improving our recruitment, streamlining processes and so forth, but there's a number of important elements of that. Foster carers need to be valued, need to be supported, and an element of that is how we support them financially. They do bring children into their houses, they receive allowances. In the context of cost of living, everything else, we need to ensure that they are adequately supported with regards to that. So one of the challenges that we have identified up until this year, there was a 12% disparity between the standard boarding out allowance as paid here in comparison to across the water, and particularly in England. Through work, and again, all of this here is in the context of finances and so forth, but we have been able to close that gap somewhat in the sense that DOH have agreed a 3% uplift this year, and there's a commitment to further balancing that out, but obviously it is related to finances and so forth. There is a very other significant piece of work that has been undertaken and led by SPPG, and that is around the fee paid model. So we have most of our foster care as a standard boarding out allowance, which is a weekly allowance, but increasingly we are placing more complex children within foster care, and there are fees attached to those placements, and there's significant variation across with it. So we have to get a standardised model across the region so as carers understand exactly the type of financial support and so forth is available. SPPG are leading in that, and we hope to have an agreed finance framework for foster care that will be standard across each of the 5 trusts by the end of next year. So we have a target about December 25. But there's a number of other elements in relation to that as well, that not only do we have to look at recruitment is one element, but we also have to ensure that when foster carers come into the system that they are adequately supported in terms of remaining with us long term, and indeed for the length of time that children need to be living in substitute care. So through the work stream there's a lot of focus on various different support models, particular emphasis on peer support, getting foster carers to support each other, and there's a number of different models we're looking at locally in Ireland, but also across the water in England, and there's some stuff that we definitely want to develop with our foster carers over the next while. Second priority, and I talked about this to the committee when I was here last month around children with disability services, there's a regional commitment to set up short breaks foster care across each of the 5 trusts so as we can significantly upscale short breaks overnight provision for children with disability and their families. And I do think with the appropriate focus, and particularly in the context of the ministerial announcement of investments for that, there's significant potential for us to make gains there, certainly over the next year. Third priority from the fostering work stream, and all of this here is linked specifically to placement sufficiency. There's also considerable untapped potential about upscaling models of supported lodgings for 16, 17-year-olds and care experienced young people. And again, we're at different places across the region with regards to that. But getting that maximised provides another really good alternative of support for young people transitioning out of care and, assisting them in the journey towards independence, basically. So I am actually, again, as chair of the work stream, there's been excellent buy-in. I get really good support through the various stakeholders, and along with Maura and my other director colleagues, there's absolute commitment to those 3 areas in terms of supporting, investing and developing it. Thank you.
Thank you, Colin. Thank you all. That has been very useful as well as the briefing. I have a number of questions that I'll try and get through as quickly as I can. But I say my 2 of my colleagues are missing, so I'm doing it on all of our behalves. I suppose the first question in relation to the ALB, and I am aware that there's strong support for the ALB, particularly from Professor Jones himself, but also from the Reimagine Collective and others, and have come out very strongly on that. So you may or may not be able to provide information on this, but given that there wasn't a consensus in the executive, do we have an understanding of what the key concerns around that were as to why people maybe felt they weren't in a position at this stage? I don't think anyone, to my knowledge, has come out and said absolutely no, but I'm sure there's some discussion around, what the concerns may be, or why they can't yet put their support behind it.
Yeah, so I mean, I think some of the concern is based on other attempts at restructuring in the past,
Okay.
and some of the challenges that has created. So I think there's specific reference to the Education Authority, and I think all of us know that there have been challenges with the implementation of that arrangement. I think there were also references to the reduction in the number of councils, for example, from 26 to 11. So comparisons made with other attempts at restructuring, and maybe those attempts not delivering what they intended to deliver. And I suppose some of that is reasonable, and I think needs to be considered. I think Professor Jones, in response to that, made the point, well, we are not trying to do the same thing. It's not about reducing something from 5 to 3, for example. That's not what we're trying to do here at all. And I think he has always been honest with anybody that he's spoken to that the ALB is not the solution to absolutely everything. I think he continues to refer to it as a platform upon which everything else gets built, and that includes all of the work that we're doing under the reform programme. So that's a brief synopsis of what,
and I think that's fair enough. Eilish, no, thank you for that. It was just to try and get and understand, because I mean, as elected representatives as well, we want to be able to consider, if we want to get this right, and we want to make sure whatever way this works, has the children, the young people and families at the centre of it. And it's not just pushing ahead, but getting a good understanding of all possibilities so that we can mitigate against anything like that as well. But I just was keen to hear a wee bit about that. My next question, and I know there's no one here in terms of the workforce work stream.
Not in terms of the workforce work stream, but Michael has led on a lot of
so
workforce initiatives.
I would probably raise this at almost every health committee meeting, but given the real crisis, particularly in children's social work services, we've seen the strikes, there's potential for more industrial action and other escalations in the time ahead. I mean, we had officials in from workforce a few weeks back as well, and I did put some of these questions to them as well. I mean, I'm a complete advocate for encouraging and making it easier for more people to get into social work, be it through a fast track route, be it through Open University and other opportunities. People who are very experienced, who are already maybe working as a social work assistant, absolutely. But we have to look after the staff that we have. So for me, retention is a massive part of what we should be doing. I feel like at the minute there's a real crisis in confidence amongst staff, and I don't say that lightly, from speaking with staff right across all trusts and unions. So I suppose, given that I don't underestimate the huge amount of work that is being done and continues to be done, but how confident are you that we can resolve the existing pressures, and what work is being done to address the concerns of those existing staff? Because yes, part of the solution is attracting more people into social work. That's a huge part of it, because we need to build up that for the longevity of the services as well. But if we've lots of new social workers with not that mix, and we talked about the skill mix earlier on of experience and support that we all need, I think that we're on. It's counterproductive, I suppose, what I'm saying. I've heard, and you'll all have heard, the examples of newly qualified social workers leaving the workforce very, very prematurely, given the experiences they're having, particularly in gateway teams, family intervention, because of the huge pressure and the really complex cases they're having to deal with due to the capacity issues. I mean, as a newly qualified social worker, you're meant to have a protected caseload and all of those things. That's just not happening on the ground. So for me, the cornerstone of us being able to deliver on these recommendations is our workforce, and preventing children from ending up in situations where it's a child protection case. So I know I'm kind of going off on one a wee bit, I don't mean to, but I suppose it's just to link it into why this is so critical to everything else that we're trying to do here.
Well,
I suppose there's two things I would say about that. One is my role has been in the recruitment and retention piece for newly qualifieds, and I suppose I would defer to my colleagues here who will know more about their existing workforce, which I think is the point that you're raising, which I understand totally. We've had to concentrate, from my point of view, on building the workforce because we started at a very low base. There were a huge number of vacancies, not only within children's services but across services in all of the trusts, and an over-dependency on recruitment agency social workers. So we have actually managed to do a number of things in the past 2 to 3 years. So as you know, the decision was taken to stop the use of recruitment agencies completely. That was taken in December 22, and between December 22 and the summer of 23 we tried to recruit those into trust posts. So that was a piece of work in itself. There were around 200 at that stage, and we managed to get about 160 of them to actually come into posts. So there was a bit of a loss there, but at the same time, there are a number of things we did, but primarily what we did was we created what you're describing as a fast-track approach to how we would recruit from our universities as people left. So at that stage, we were training 260 social workers per year. The most we've ever trained is 300. But since then, I'm glad to say that we've actually been able to increase that, both with the OU, which is a new initiative. We brought the OU into the delivery of the degree in social work in Northern Ireland for the first time. It was previously aligned with England, but we actually got it aligned with our own degree here. So we now have 25 OU commissioned places, and the trusts also commission places on top of that, so there are DOH commissioned places. And just this year we've been able to secure another 40 social work places, so it brings us the first time to 325 social workers being trained, which is substantial. But what was happening previous to what we did in 2023 was that social workers were qualifying and not being recruited very well, and our processes were very poor. That has changed, and in the past 3 years actually, we're now into year 3. So of the 260 that came out in 2023, not counting the OU people because they're slightly different because they're employees already. So we were able to recruit over 202 I think it was in our first year, and those newly qualified went into posts.
260 did you say? Sorry,
260.
Okay.
So obviously there are other employers, so with probation, youth justice, education authority, so people don't always want to work in trusts, and perfectly reasonable. So over 200 in the first year, and just last year, in the summer of last year, we had 221. So we've managed to do that really because we closed off the option of going into recruitment agencies, and it kind of forced that movement into trusts, which really has helped to stabilise the workforce, which is exactly what we wanted to do. In terms of the experience that newly qualified social workers have, and certainly my colleagues can talk to you about that, I would be pretty close to the final year students. I would meet with them regularly, describe to them what it is going to happen in the recruitment process, and then would follow through. Each of the trusts has an AYE, first year of employment lead. So again, I would make contact with them regularly, and there are lots of things going on in trusts that were not there previously, which to the same extent, which are designed to support our newly qualified. There's a fantastic range actually within each of the 5 trusts of supports in place. What I would say is we have no problem at all in getting newly qualified social workers to come along to talk to our final year students and tell them the positive experience that they've had. People are queuing up to do it. So that's in both institutions. So it's up at UU and at Queen's. And so there is a counter to what you're saying in that there is a very positive experience, including for those social workers who have gone into frontline family and childcare teams. So it does work both ways. It depends entirely on the team that you go into. It depends on your manager. It depends on the capacity and the demands. But as the intention was that as we raise the number of social workers in posts, the amount of pressure diminishes.
I take your point, Michael, and I'm not saying that every single team is having that experience, but we've heard very, very stark figures in relation to the number of vacancies, particularly in children's social work teams, and that's my concern. So I think it's excellent that I'm a social worker, so more and more people are going into social work. Fantastic. They're not all going into children's social work for a start, which is where we have this real crisis, and in children's disability as well, not just family and childcare, as in child protection and family intervention. But certainly the real concerns I have are around those situations where it is so complex, it's so high risk. I mean, I think even when I go back to when I first qualified, the risks that we're presenting in homes are much greater now, given the huge changes in society in that period. So some of the experiences that particularly newly qualified social workers and very experienced social workers are now facing. I mean, we see the figures that Ray Jones quoted at the time of the review. There was 4,000 children sitting unallocated, I'm assuming. Isn't that right? Just correct me if I'm wrong. Right? That's growing, that's not reducing.
It is reducing. It is. The number of unallocated cases is reduced by about 15%. Between March and October this year, yeah.
Because the last figure I got was 4,100, so that's why I want to.
The number of unallocated cases has come down.
It would be good to get those that out, but I suppose what I'm saying is it's still very high, and I know that, and that's in disabilities, children's disability as well, and that's obviously due to workforce pressures. So is there anything, so it's on one hand it's good to hear that we're here getting lots of new social workers and they are being recruited. I mean 202 out of 260 is brilliant. How many are staying? And it goes back to some of the conversations we had in the last briefing about data collection. So how many are we actually keeping? And also those staff that we're hearing are off on sick leave and things like that due to stress, who are very experienced, but we are seeing the real impact on what are we doing in relation to that. So you understand what I'm saying? It's coming out from all angles, and
absolutely we want to know that social workers are staying. I mean, it's not about filling posts and leaving people, with very difficult caseloads and no support. This is about a career in social work and a lifelong career, and that's what we're trying to do. And certainly,
I mean, there's working on in relation to safer staffing too. So the chief social worker is leading on that, and I think there's a piece of initial research was done that was about baseline analysis. The next phase of the work will actually look at caseloads. So what are people carrying? How are those caseloads composed, etc. How much of it is about professional social work tasks and that. So there are a number of things that I think need to happen here to address the problem. Recruiting is one of them. Retention activities, another. Work around safer staffing. So there's no one thing is going to resolve.
And that's the point I'm making.
The issue. It's a whole package of measures, and I do think we have a package of measures in place. Now, some of it's going to take time to deliver too. It's not all going to be delivered overnight. Is there anything you wanted to add?
Maybe if I could just, and it might help the committee, the work as outlined by Michael has been very beneficial in at least enabling us to stabilise to an extent. Workforce supply for sure remains a challenge. The fast tracking of students into the system has been very positive, but maybe just to assist, for example, in my own trust, in the Southern Trust over the last 12 months, since probably, if you go back to 23-24 year, through the fast track initiative, we appointed 34 newly qualified staff into the system, vast majority whom are still with us. In fact, nearly all of them are still with us. However, we still lost, in addition, almost 20 other social workers, for a combination of reasons, whether it's career progression, personal choice, increasing issue of young people travelling and so forth. So it's a very slow incremental gain with regards to that. So we are hugely mindful of the need to seek to retain as best as we can. Unfortunately, we do have high numbers of unallocated cases in the system because as directors and social work managers, we know we can only ask so much of staff, so we're very mindful of seeking not to overload skills mix. We are moving at pace to seek to upscale that so as we are able to deploy what available social work resource we have on absolutely the most needed and the best targeted. We're very mindful with regards to our newly qualified staff, otherwise assessed year in employment, and certainly in my own trust, and I know is replicated elsewhere, is putting very dedicated wraparound support in terms of mentoring, supervision processes, coaching, additional support from outside the immediate team, with a focus to enabling them, to receive as much support as possible in dealing with hugely complex family situations as you just outlined.
Thank you. And I think that's it, Colin. You've kind of captured what I was saying, is that yes, we've plenty coming in, but there's also how is that actually touching the sides in relation to what's needed when you still have a flow going out the back door. And I think the most important part of that then is that continued engagement with the unions, with the staff, through the Chief Social Worker's Office, because we really need to get a grip of that, because for everything else I think it won't work as well as we want it to unless that's addressed. The other issue I wanted to raise is in relation to children with additional needs, and particularly in relation to transition. And I mean, I've had concerns raised with me, across various trusts around cases that are still, sitting unallocated in those respects. And then there's that gap for children even from about age 14, depending on where they are within the system onwards. So there's lots of things as they start to get closer to the age of 18 and then are getting ready for transition into adult services around capacity, and assisting them if they need a mental capacity assessment to enable them to access whether it's universal credit or other financial things like that start to change. And there just seems to be a real gap. So within the work that's happening, is that something that is being looked at, particularly around that transition piece?
So under the Children with a Disability work stream, one thing that they have developed is a transitions protocol, which will now track children from age 14, children who are making the journey from children's services to adult services. I think the intention is to I think they've already created like an easy read version of that protocol, and they want to test that with families. And the intention, subject to everything being okay, is to pilot that then early in the new year. The whole purpose of it is to improve planning for those children, and also to deliver a more consistent regional approach, because it's another area where things are currently done differently across all of the trusts. Yeah. So we can get some more information from you.
Yeah, I think I had seen it about the transition protocol, so that's why I had raised it. And that easy read resource is interesting, because I recently met with a group of parents from across South Armagh, South Down, Newry area, who children and young people who are at that kind of stage, and they actually said around, even as a parent, when your child's first diagnosed, your whole life is then consumed by navigating of what's out there and where you go, and it really does depend on maybe who your key worker is and what information. You're very dependent on someone to give you information. They had alluded to the idea of, if you got something like that at the very start of your journey as well, like a resource of something, just something to consider. Just as we were talking there, it came into my head about helping people to navigate. But yeah, I'll get more information, that particularly that post 14, because one of the issues they had actually raised was around, if you have a child, given the huge capacity issues in education in special schools now, a lot of children who normally would have went to a special school are in mainstream. So if your child's in special school, they're there till they're 19. If your child is in one of the SPIMs or whatever in a mainstream school, they're only there till they're 16. Some maybe even a wee bit younger, depending on their circumstances. But there's that massive gap. So then that leads to another issue, that there's no provision within health for those children who aren't then at school, if you know what I mean. So there's a gap in itself around that. So that's why that transition protocol, I think, it would be
There's another piece of work too that's being led by work stream 6, and that's the development of a children and families charter. So Michelle Janes from Bernardo's and I lead that, or co-lead that work stream, and that is intended to do exactly what you've just described, to help children and families actually navigate their way through children's services. So that work has already started, and work will take place early in the new year with a number of different groups to ensure that we get the charter into a shape that is appropriate.
Okay, no, thank you for that, Irish. And I suppose you mentioned this, I meant to say this under the workforce piece, the launch of the social care workforce strategy today. Will we get a copy of that at some point?
Yeah, Michael, I think you brought copies along with you.
Oh,
we will ensure that
everybody in the audience.
Ensure that you get
No, I mean, I think it's given, I suppose, the questions and the issues I've raised there, and I have met with NISC and others. I'd sponsored their event some time ago as well, so it will be good to see what's included in that going forward. But thank you. That was very useful. Thanks a million, Danny.
Thank you very much, Chair. As you mentioned, thank you very much for that comprehensive overview. That was very good. I have a couple of questions now, starting with the foster carers. The work that foster carers do across Northern Ireland is absolutely invaluable. I have a couple of questions just around what interaction are you having with foster carers when it comes to co-production of policy? Are you involving them and inviting them in at the policy design stage in order that they're able to shape policy?
Yeah, as I said, through the work stream itself, there's quite an extensive process of direct engagement with foster care. So, for example, each trust has its own various different foster care forums, foster care groups with regards to local engagement. We also have sitting on the work stream the fostering network, whose race and DETRA is essentially supporting foster carers, engaging with foster carers, using foster carers in terms of feedback information about policy, strategy, all of those matters. So an absolutely central component of what we're doing through the work stream is direct engagement. For example, the regulations and guidance around fostering, there's an extensive piece of engagement being led by the fostering network with a number of sessions engaged to dissect, go through that, seek feedback. But the issues around even the priorities that I've identified in terms of the work stream that I'm chairing, a key component in that is absolute engagement on a recurrent, ongoing basis with foster carers.
One of the issues you had raised earlier as well was the regional variance in the uplift to fees and allowances for foster carers. Now, I've been approached about this, and there does seem to be quite stark differences between trusts. I'm wondering, could you speak to that? And I know you'd said that there is work ongoing.
Yeah.
Why such stark regional variances, and what is being done to equalise that?
The variance, the uplift, is standardised across the piece. Basically, that's what I talked about earlier on, the 3% uplift that was secured, that's been applied to all boarding out allowances, so there's no ambiguity, inconsistencies with regards to that. What is much more complicated is the fee paid model. So you have the standard boarding out allowance, which is essentially a living and support allowance that foster carers, and it goes from a range of again, it's approximately £145 to approximately £220, depending on the age of the child per week. But in addition to that, dependent on the level of complexity, and again, the committee will be well versed in relation to the challenges faced there, but some children come into the care, or nearly all children come into the care system, but some with very varying degrees of trauma, background experiences. Our direct intention is that we manage the vast majority of those children in foster care. In acknowledgement of complexity, we do have to get that increased level of specialism and capacity within foster care, so they will attract certain levels of fee depending on complexity and indeed the ask from trusts with regards to what that child needs. Because of different situations where each of the 5 trusts are coming from in terms of how residential care is used, how various other different models, there has been significant divergence with regards to what level of fees are being paid. Generally that at this moment in time is decided upon within the respective trust family placement services. What we are absolutely committed to do is to have a regional Northern Ireland wide fostering finance framework that will standardise all of that, because that's significant in terms of clarity for prospective foster carers in terms of the supports available. So that is something that we absolutely acknowledge and we very, very much need to standardise.
Thank you very much for that. One of the things you were also talking about was listening to what Liz was talking about retention within the social work workforce. Now, it occurs to me that we've heard about people leaving mid-career, and it's similarly in other areas within the health service. It would occur that there's a pool of people who have left mid-career with significant amounts of experience who are not working within the service anymore. Is there an attempt to try and engage with them and to possibly re-recruit? Is that something that is possible? Is it?
I think it's a very difficult thing to do. It's certainly something we've looked at. It's possible to keep track of people through the NISC register. So the NISC register is a universal piece. So we're able to see when people leave that register. It's updated daily. So there's always going to be movement in that workforce. There are currently about 4,800 social workers within the trusts, about 6,500 social workers on the register, so that you can see the difference there of the other employers. I suppose it's very difficult to reach people who have actually left posts, so we've found that quite difficult. But we're also very mindful in planning for the future that we know that each of the 5 trusts, 30% of their workforce, social work workforce, are over 50. So that's universal across all 5. So that obviously needs to be part of our workforce planning. So I don't want to be disparaging towards my social work colleagues. I am a social worker, but there can be a natural time when you've done enough frontline social work. And I think that we have to acknowledge that and see that there are other roles that people can play that aren't necessarily frontline social work. Certainly my own experience, that would be my experience. So we're certainly looking to see can we do that, but the reach is the most difficult part of it.
Well, we did some of it during COVID. We did bring staff who had left the service back to support trusts during COVID. Can't remember just how successful it was, but it's probably something we could look at again.
More realistic about return.
I would say that isn't the biggest problem for us. So we are retaining our staff within trusts, but there is movement within trusts. So there's promotional opportunities, there's maternity leaves, there's move from children's, for example, into adult services, and it's that level of movement within. So in the Northern Trust, our attrition rate's very low. We keep our staff, but they're not staying necessarily in our frontline childcare teams. And because our recruitment only touches annually, whenever we get our influx of newly qualified social workers into June, into July, we're healthy, our waiting lists come down, everything's looking good, but promotions come up, movement comes up, maternities come up, retirements come up, and staff move. And we have no further opportunity to bring newly qualified staff back in until the following year. So between this time of year and into the summer is always an awful time for teams, really, because as one leaves, they know they're not getting somebody in to fill those gaps. But leaving the career entirely, mid-age or whatever, isn't something that I would necessarily be flagging as a big issue. We do, in fact, actually have quite a number of staff who come back that come back post-retirement to undertake a couple of days specific pieces of work, and they remain on our bank, and they're a real stabilising influence for some of our teams. They're really very helpful, actually. I think our biggest issue, and I think we have achieved something this year, which was about retaining the AYEs for a year. So there were no advertisements for jobs for Band 5s this year, which meant our Band 5, which is our newly qualified social workers, were retained in the job that they were recruited to back in the summer. And they have been retained there for a year. So now they're in a position to apply for qualified social work jobs, but actually now they've had a year of being in teams, they're choosing to stay, which is really very positive. I think before, our experience has been newly qualified staff have moved into frontline teams, have been faced with vacancy levels, high caseloads, a level of anxiety, and they immediately want to move on. Because that door wasn't available or open to them for this last year, they've settled with teams. They've been really well supported and maintained and by our training teams, but also within the team, and they have chosen to stay. So I think there's some good progress, but we have a long way to go, and it remains very challenging, specifically for children.
And maybe just to add, to your specific question, certainly we have excellent support from our respective HR departments, maximum flexibility in enticing and facilitating anybody in the circumstances you've described who would express an interest to come back. There isn't a lot of evidence that there would be high demand for that, but certainly if you know of anybody, send them our direction and we will absolutely accommodate.
Danny, can I just come in just very quickly on the vacancy piece? And I'm sorry, I don't want to hog your time, but it's just because as we're talking, I suppose the bit for me is that where those staff have left, so newly qualified social workers coming out of social work altogether, or staff who have been off on leave, and it's the levels of vacancy then that are there, or we ask the department all the time for figures of vacancies, but they only are able to give us those that are being recruited for. It's the ones that aren't being recruited for that we've repeatedly raised concerns, because there's still vacancies, but that data is not available, and that is what has an impact on teams. And I've been in teams where vacancies have lay for a long, long time, recruitment doesn't happen, and that adds to the pressure. So whilst there's progress, I think there's still significance, and I know that's what you've said, more anyway. I'm not taking away that. Where those are critical issues we really, really need to address as well. So it's just to kind of take it back to, because I know what you mean around promotions, and that's natural within teams, but I do think there's still a really severe issue there, particularly in frontline services and children's that we have to address.
From maternity leaves, we know we will not fill a maternity cover.
Some people don't come back.
We used to be able to,
yeah.
But we can't do that anymore.
There is a bit of a change in culture, really, because of the removal of the recruitment agency availability.
Yeah.
So team leaders and heads of service, I think, are much more attuned to the fact that they actually make sure that any vacancies are, that they're progressed as soon as possible, because that's the only way that they're going to be filled, as opposed to a temporary recruitment agency social work.
Sorry, Danny, for intervening.
You're grand.
Thank you.
I appreciate that, and I was expanding on the point. I also wanted to raise the unallocated social workers, and particularly children in transition. It is a big issue, and I know there's lots of very worried families, so I was very glad to hear just about the work that's being done on that. And certainly something within this committee is that there is an urgency about the implementation of the recommendations of the review. Is there a timetable in particular that you would be able to share with us, that you can see where reviews are being, or recommendations are planned to be met?
So what we've now done is, that there are 53 recommendations, and 10 of those I'm going to park because they relate either to the ALB or to the Children's Minister, or a couple of recommendations that are the responsibility of other departments, and those departments are acting on those recommendations. Of the remainder, then 34 recommendations have been accepted, and 27 of those have actually been located with the reform programme, and I've said the further 7 then are the responsibility of the department. I mean, the purpose of these sessions is to give you a sense of the progress that is being made. So I just want to assure you that the reform programme is now the mechanism through which we will deliver the majority of the review recommendations. And through these briefings, I'm hoping then that you will have a sense of when recommendations have been acted on fully. So there's a number that we've closed already because we have taken them, I think, as far as we can take them. So I'll give you an example, one related to making case management reviews quicker and more participative. So we've already undertaken a review of that process, and we've got a report that made, I think, something like 18 recommendations, and now we're acting on those recommendations. There's a couple of others.
So just with that, so you've closed that recommendation.
Yeah.
But the recommendations within the report are still being made. Is that correct?
So, no, the recommendation was I'm just using this as an example. So the recommendation was to actually have a look at that process, to make it a better process than is currently the case. So we've done that. We've done that. That has been reviewed, and we now have a pathway to improvement through the recommendations made by that review. It's just an example of one that we have actually closed.
It sort of strikes me that it shouldn't be closed until the recommendations that the report have made have been implemented.
Well, I mean, if that's what the committee would like to see, we can do that. So, I mean, it made 18 recommendations. Some of those were for the department, some were for other bodies. We can continue to report on that particular recommendation if that's what the committee would like to see.
Okay, I think it would be a bit clearer for us, but I do appreciate that there is progress being made. So I appreciate that. Thank you.
Okay, thank you, Danny. Diane.
Thank you, Chair, and thank you for the presentation. The first is maybe a more niche area for Colm. I was recently speaking to our colleagues on the Justice Committee who were receiving some information on the concept of bail fostering. And my understanding is that the Southern Trust has a pilot project in relation to this, and that a foster care in the Southern Trust will have an allowance of around about 27,000 per year, but someone involved in the bail fostering scheme will have an allowance of 36,000 per year. Can you, one, tell us, I mean, I understand the concept, and I mean, it's someone who chooses to do this, it's an incredible thing to choose to do. It's incredible. So I understand the difference in pay scales. I get that. But just to expand for the committee, because I'm not sure whether anybody has, I hadn't realised about it, so I'm just not sure how much is known about the concept, whether you intend to introduce it across all of the trusts, and whether you will be seeking a contribution from the Department of Justice in relation to the cost of this as it progresses.
Yeah, thanks, Diane. I suppose the context with regards to it is that it started for quite a number of years, and yes, it is specific to the Southern Trust. Again, you'll be familiar from Department of Justice colleagues, children being remanded into JJC should be in absolutely exceptional circumstances. Unfortunately, on occasions they will be remanded, but it should be for the shortest period of time. So on occasions, thankfully not hugely often, but on occasions young people not necessarily care. In fact, almost exclusively non-care experienced young people are arrested and remanded into JJC because their complexities, family for various reasons can't offer a bail address, and they ended up then being remanded because there was no exit for them. Certainly in the Southern Trust we had a particular challenge because of perceived complexities, anxieties of carers and so forth, and understandably most of these are on an emergency basis. It'd be very, very difficult to get a standard foster care to agree to a placement of that nature, so they ended up being remanded. We have progressed, and it's gone beyond a pilot now. We mainstreamed it, but we had excellent support from the Youth Justice Agency in terms of putting the support networks and so forth in to a particular very experienced foster carer who agreed to come into the scheme and to make themselves available for emergency bail placements. Important to point out, these cases are hugely complex. There's usually no school provision. There's usually significant trauma, significant complexity around risk-taking behaviour and so forth. So it's a massive ask in terms of what is essentially a family to offer a bail address. So, for example, you almost exclusively need to have one parent at home. You know, it's not a case that, one foster care at home on a full-time basis. So immediately when you're doing that, there has to be significant financial support to enable them to do it. So the fee that we pay is reflective of all of that there. We, as I said, got excellent support from the Youth Justice Agency and continue, because one thing is securing bail and placing the young person, it is having the appropriate supports then, because usually when bail is granted, there are fairly significant conditions attached to that, which requires the social services, but also through bail support via the Youth Justice Agency. Important to point out that it's not something that is easily set up. It took us probably the best part of 2 years to successfully identify and put the whole processes in place for that placement. But it's been very successful in the sense that we have not found ourselves in a position that we've had young people from the locality remanded into JJC and that we've been able to exit them out of it. So to answer your question, yes, that will form part of the overall strategy, in that we would want every trust to be able to have that bail fostering option.
Will there be a request for a contribution for that from the Department of Justice in terms of the funding of that particular piece of work? It seems to me it's an amalgamation of justice, because you've explained of all the complexity, and I do think I'm full of admiration for someone who can take on such difficult, and maybe give them a start that they might not otherwise have. And I think that I'm absolutely, I think it's an incredible thing for someone to do. But I'm just interested from a procedural point of view. Is this something that Justice are going to be involved in, not just as advisors but as financiers?
Yeah. So the Youth Justice Agency locally has absolutely been more than just involved in advisory, the practicalities, but your question probably needs to sit at an interdepartmental level, in the sense that
it's something that we can raise with the I just think
it's an interesting thing that it is equally a justice issue. But I do think it is an amazing thing to do. Just sort of two other things, and if you don't have the answers to the first one, I would appreciate, probably the committee would like to know the answers to it as well. In terms of the 2 million additional money for respite breaks, that is to the end of this financial year, and then the additional 13 million, and I know, Colin, that you're planning as to how that would work out. Can we have an idea of what that additional 2 million buys us? Yeah. How many children it helps? What additional respite breaks it gives for children? You will know the cases that you and I talk about. But just so we have a sense of that, and then how you plan that for the following years with the additional 13 million that's coming, because that should make a significant difference in what is again a complex and difficult problem.
Can I take that one? So, I mean, the plan, Diane, is to have a regional plan setting out how that money will be spent on what, by when, and there'll be outputs and outcomes associated.
The committee will get to see that
too. Now, I think officials are coming before the committee in March of next year, so I think you'll probably have a better sense then.
I think we've written to the department asking for a breakdown as well. On the back of the trust meeting that day, we had raised it that day.
I think the regional plan is the answer to your question.
So it'll be a regional plan.
A regional plan.
But I just maybe to add to that, we are moving at pace in terms of in-year upscaling, and I did provide the committee with an update with regards to that in terms of upscaling our residential short breaks provision. We've already had agreement with a number of our voluntary and community sectors with regards to what they can do in year in relation to day opportunities, and Chair will be aware of particular unmet need in the Newry locality, which again through a voluntary provider we are now able to secure additional provision in the knowledge that that in-year money is available, but significantly and really welcomed that it becomes recurrent, so there is immediate capacity we're upscaling within this financial year. Well.
I mean, I think that's one of the brighter things that we've experienced. Just as a final, I know all of us will have been reading the terrible story of the little girl in England, Sarah Sharif, and the equally awful story of the little boy from I think Dundalk, who seemed to just disappear, and social services, no one has traced that child. I think that's enormously sad. Do we have procedures in place so that can't happen within our network? That's an awfully hard question to answer. I know that.
But a very relevant one.
But a very relevant question. That child was abused possibly from she was born, died probably a horrific death. And we've lost a 6-year-old boy.
I think to answer your question, yes. So SBNI, the Safeguarding Board for Northern Ireland, has policy and procedures that all professionals and all agencies are signed up to. The circumstances of that child in England will be subject to a case management review, so we don't know yet the full range of potential missed opportunities in that case, but certainly the Children's Commissioner has identified some legislative changes that would assist. One, for example, was around homeschooling, and I can't remember the couple of others. So there are big legislative pieces that she certainly was identifying that would support greater interrogation and interagency worker than exists currently. But we do have policies and procedures, but sometimes we continue to get it wrong. Sometimes our environment doesn't support our frontline social workers to always get it right because of all of the issues that we've talked about. But we try to work hard to learn from those as much as we can, and that's what the case management review process is around within SBNI, and all trusts and all agencies participate in that. But we can't say never.
And it's probably important to add as well, and we touched on it earlier on, the site visit to Camden, which talks about multi-agency front door, and that would include education colleagues, police colleagues, numerous else, and that's certainly something that as a director, and I know I'm speaking on behalf of my director colleagues, that we are absolutely enthused and committed to introducing here.
Just before I take Alan in, I think on that point, I mean, the other issue is that we live on an island, and particularly when you look at that little lad, Kyron. I mean, there was part of the issue there was that they said that potentially he had been moving north. So at present, as this isn't something I'm actually aware of, is there work ongoing, like on an all-island basis, where that there would be discussion between, on tracking children, particularly if they're already known to social services, whether it's Tusla or vice versa here in the north, because if there's a gap there, that's a potential. From my very, very scant reading of that case, I don't know the ins and outs of it, but I think that there's a potential that someone has said, oh, they've moved, but I don't think anybody has followed up on that. I don't want to make assumptions either, but it's just to understand that kind of cross-border working.
There is a cross-border protocol
that
sets out how authorities in Northern Ireland work with authorities in the south of Ireland, and that was developed under the North-South Ministerial Council Child Protection arrangements. It was only recently updated. I think within the last number of months it was updated and reissued again, and there has been a lot of training and everything around the operation of that protocol on both sides of the border. Again, we can get you more information on that.
Yeah, no, it's only just come into my head as we were talking there, and because another issue came up recently with me, and I'd written to the Minister on it, was that if a child who's known to social services in one trust, it presents in hospital in another trust, they don't necessarily inform the trust that they're known to say on Child Protection Register, or there may not be that. So that came up as an individual issue, but that I don't know, is that the case?
I mean, that's the purpose of the Child Protection Register.
Yeah, no,
you know, if it's on the register,
okay, so in that
then
case, that maybe that should have happened, and it came to me through a counsellor, so I must go back, because I did provide information, but it wasn't overly clear. So that's just, sorry, I'm digressing again, but they are important, I think, is pretty given, because I think with all the challenges we've outlined today, we don't want to see a case like that happening, you know. So thank you for that. Alan Robinson, sorry, thank you for your patience.
Thanks, Chair. Colin, I just wanted to ask a question around the conversation you had earlier in the session with Danny, and that was with regards to the financial model for foster carers. Obviously, given the pressures within foster care, and as Diane had rightfully highlighted, the work that they do and the need for a reward for foster carers. Did I pick you up correct that the financial model between the trusts wouldn't be in place until December 2025? And given that that's a year away, is there any reason why it will take that long? Could you explain the body of work that's involved? Why we will have to wait? Foster carers will have to wait a year before they see the outworking of a new financial model.
Just to be clear, it doesn't have any immediate impact on the financial support that foster carers get. What I was trying to explain, because trusts come from very different places, up until this point, fee models were by and large managed within the existing 5 trusts, and because of different local needs, different ways how children's residential care was deployed and so forth, the ask of fostering was different. So there have been significant divergence over the past number of years with regards to that. So one, it is hugely complicated in terms of payments that have been quite historical, particular to specific children. Diane correctly pointed out the issue around bail fostering, which is unique to the Southern Trust. That's but one example. Numerous different other examples of intensive support fostering schemes, specialist fostering schemes, right through, to a small minority of fee paid, probably bordering on professional fostering households. So that variation across the region, the work we're talking about is seeking to standardise it, define it, analyse it, and it will take the best part of the next year to get a really, really clear handle on that. It also requires very specific engagement with foster carers, existing foster carers and so forth, because what we don't want to do is apply a scheme that doesn't resonate with our carers, that doesn't make it attractive for carers coming into the scheme and so forth. So it does require that level of analysis and detail. But it won't impact on carers at this moment in time.
Well, that's good, Colin. And do you see that as the hard and fast deadline, December next year?
I would be optimistic. As I said, it is being led by SPPG, very much linked into the fostering work stream, and we are putting very tight timelines around that. So yes, that is the commitment that has been given at the moment. And I would feel optimistic that we should be able to wrap that up, yes.
Okay, thanks for that, Colin. We really appreciate it. It's a good session. Thank you.
Thank you, Alan. And Colin.
Thank you, Chair. Just 2 quick questions. One was on, I'd asked the Minister about issues to do with non-compliance and in terms of children, and it's just really more just for information. Some of the table that was replied to me was that we have 340 unregulated kinship care placements for children, and that the number of unregulated care placements has increased from 172 to 219 in the year. Does that mean that if it's unregulated, that we have children that are actually known to social services and on a register, but we don't?
The reference to unregulated is the completion of an assessment within a time frame specified within regulations. So I think the time frame is 16 weeks. Unregulated means that we haven't, or trusts haven't completed that assessment within that time frame. It doesn't mean that nobody has eyes on that arrangement.
Regulation is the 16 weeks rather than the care placement that they're in isn't regulated.
Absolutely, absolutely.
And support is maintained throughout and actually very high levels, because while they remain unregulated, there's weekly visits into that family home. There's financial support that goes in, so there's lots of protections in and around it. It is, as Eilish says, it's the not meeting the target for the completion of the assessment in order to approve them one way or the other as kinship carers.
And probably important to point out, they're almost exclusively kinship placements, relatives, extended family and so forth, where there's a fairly significant degree of knowledge of the child and indeed the child of the carer. But when we're into the looked after arrangement, I can assure the committee that all basic checks are immediately carried out immediately with the placement of the child. The rest is, again, there's almost a similar standard applied to a kinship foster care as a trust foster care, and it is a detailed process, and even with the best will, getting it wrapped up in 16 weeks is challenging.
Now, in terms of the arm's length body, I know you had mentioned it but didn't quite hear the full sentence, so it dropped in and out of that bit at the very, very start about the youth services and their involvement within the arm's length body. What stage is that at or not at, and what would be the hope or the intention with that?
I mean, that was Ray Jones' recommendation. So he recommended an ALB plus, which he considered could involve children's social care. So the 5 trusts services, but also education services, including youth services. Now, none of that has been agreed at this point in time. I mean, I made the point that there was no consensus among the ministers who were consulted on establishing an ALB. So we are not there.
We did take some evidence at an APG that we have on youth participation, and one of the points that was being made very strongly was that what we shouldn't do with the arm's length body is wait until everything is agreed before moving forward, that there should be as much as is agreed before moving forward. Which of those two models do you think is likely to be the way forward? Is it going to be, say for example, if we don't get education buy-in but we do get justice and health, then we'll move forward with that? Or will it be a case of until we get everything as is envisaged within Ray Jones before moving forward with that?
And I think it could only have been something that was done on a phased basis anyway. I don't think it would make sense to try to bring all of that together in one fell swoop. It should be done on a phase basis. The Justice Minister, just for absolute clarity, has indicated her support for an ALB. I think she's on record as being supportive. So I just want to make that clear.
Is it going to happen? In other words, I mean, regardless of what Ray had suggested about what should be in it, do we feel that there is going to be that arm's length body? It'll be a single authority for all of the social services for children within the various trusts. Are we going to see work starting on that soon, or?
Okay, so the only thing that I can say at the minute is that the Health Minister is currently considering his options. So there's no final decisions made yet, and I'm just making the point that the Justice Minister has indicated her support. So assuming that things progress, I think you could expect to have youth justice services sitting alongside social care services. That's assuming that things
as one progress. Body, not as 5 separate bodies and 5 trusts.
As a single body, with a number of different functions then brought together. Yeah.
I think the Minister actually has indicated, did he not indicate in a press statement recently that he is supportive of the arm's length body? I thought it was...
The Minister again is on record as being supportive, but he's also on record as saying that he thinks that it should be something more than just simply bringing 5 trust social care services together.
Interesting times. Thank you, Chair. Thank you.
Okay, look, thank you all. That's been a really, really good session. I think, as Alan had said too, it's good to get into some more of the detail and see now how we're moving forward. So we really do appreciate all of your time and the work that is happening. So thank you all.
Thank you very much.
Thank you. Okay, members, I know we're over time as usual, but I'm conscious that we have another. We have officials in attendance for this next session. So I know, Diane, you need to leave shortly.
Do you?
Yeah.
It's just a couple of questions I wanted to ask.
So we'll have
keep anybody long on that.
We'll move to that now. So item number 7 then is the draft SI 2024, the Human Medicines Amendment, Modular Manufacturing Point of Care Regulations 2024. If I could refer members to tab 7, page 678 of your pack. The committee will remember that we were briefed on the draft SI on the 21st of November this year, and we had indicated we were content with the merits of the policy and that the department make the SI. At last week's meeting, the committee considered the draft SI and agreed that officials attend today just to answer a few additional questions. So we welcome back Chris Garland, Senior Principal Pharmaceutical Officer, and Sean Curley, Principal Pharmaceutical Officer. We do appreciate your time and apologies we're slightly delayed. So if we could just open up to any members if there's any questions you want to raise at this stage. Diane?
So I just wanted to raise, I noticed that the basis of this is it's a UK draft framework for how this would work, but that your note said that in Northern Ireland it would have to operate within the confines of applicable EU law. So I just really wanted to know, one, what contact you'd had to understand how robust that framework would be should EU law change, and how we would then differ to the rest of the United Kingdom, or is there a necessity for the whole of the United Kingdom to have that dynamic alignment with EU law in order to have this operate in Northern Ireland, and what the input of the European Union was in relation to the framework?
Thank you very much, and thank you, Chair, for the opportunity to come back and brief members. So I suppose while the Windsor framework does resolve the concerns that had been expressed by the pharmaceutical industry around the long-term supply of medicines to Northern Ireland, and it does that by two mechanisms: disapplication of the Falsified Medicines Directive in Northern Ireland, but also facilitating UK-wide licensing of medicines by the UK's competent authority, the MHRA. However, other aspects of EU law in relation to medicines, and namely Directive 2001/83/EC of the European Parliament and of the Council in relation to the Code for Medicinal Products for Human Use, that those aspects do continue to apply in Northern Ireland. And that includes the EU's regulatory framework for manufacture of medicines. The purpose of that, I suppose, that continued alignment with EU law on the manufacturing of medicines, it does facilitate the dual market access for medicines manufactured in Northern Ireland to both the UK internal market and the EU single market. However, throughout the process of this SI, the MHRA has engaged throughout with the EU to ensure that legal framework on that's proposed in the SI, that it is consistent with EU law as it applies in Northern Ireland. So I suppose in relation to your specific questions, the framework as it's drafted, it applies equally throughout the United Kingdom. It applies on the same basis in Northern Ireland and in Great Britain, and it will be applied by the MHRA equally on that basis. The MHRA and the UK government have also engaged with the EU throughout the process and have notified the EU about the SI under the Technical Standards Directive. and no concerns were raised by the EU. I think another important point just worth noting here is that the EU law in relation to the specifics around this framework is currently silent in that sense. So the UK is, I suppose, is ahead of the EU in this regard. We know that the EU are looking at this themselves in their future pharmaceutical reforms. And the MHRA are working very closely with all international regulators, but as well as that the European Medicines Agency, trying to work towards an internationally harmonised regulatory framework. But so suppose as we are at present, in terms of any divergence between Northern Ireland and Great Britain, the framework will be applied equally across all parts of the United Kingdom.
So the second part of my question, so when the EU starts to look at its pharmaceutical framework and reform of it, and I mean, I'm presuming with new developments that's something that's done on a very regular basis. Where does that leave us vis-a-vis the rest of the United Kingdom? Should there be changes made to EU law?
Yeah, I'm happy enough to take that one. So we're aware that the EU have proposed reforms of their pharmaceutical legislation, so we're aware of that. The MHRA are aware of that as well, and part of that is decentralised manufacturing. So this SI is very similar in terms of decentralising manufacture. What it does is allows innovative manufacturing at decentralised sites, which obviously ensures the high standards of safety, quality, efficiency of those manufacturing. So we are aware that the EU does have that. We work very closely within the department. We have the EU Future Relations branch. We also work with the Department of Health and Social Care, the UK government lead on that in England, and also MHRA. So if there are any differences early on, we will catch that, and there are the usual mechanisms that are there, such as scrutiny through the Democratic Scrutiny Committee, etc. But what I should really point out is the Windsor Framework arrangement for medicines is coming from the 1st of January, so medicines will be licensed on a UK-wide basis. These products will be manufactured at the point of care, basically the site they are manufactured at is generally where patients are going to get it. So the potential of these leaking into the single market are very low. So in terms of the future, there may be divergence, but how that is handled, it'll be through the usual mechanism that the UK government and the EU have. But looking at the general risk in terms of how they're manufactured and how they are licensed, the risk would be very low.
Okay, thank you for that then. No one else has indicated at this stage. So just if I can ask members, are we content then with the draft SI?
Content.
Yeah, so we can just if I can ask for a formal agreement then. The Committee for Health has considered SI, the Human Medicines Amendment, Modular Manufacture and Point of Care Regulations 2024 and recommends that it be affirmed by the Assembly. Great, thank you. Thank you for coming back.
Thanks, Christmas.
You too, all the best. Okay then members, item number 8 is the SR 2024-106, the Bread and Flour Amendment Regulations Northern Ireland 2024. If I could refer you to tab 8 of your pack, including the Clerk's Memo, page 758, and the SR at page 760. This statutory rule provides the mandatory addition of folic acid to non-wholemeal flour to help reduce the number of neural tube defects affected pregnancies and for changes to the required quantities of calcium carbonate, iron and niacin. There are exemptions provided for wholemeal flour and flour produced by small mill. Just to remind members that the SR is subject to negative procedure, and the committee considered the SL1 at its meeting on the 14th of November 2024 and agreed that it was consent with the merits of the policy proposal. The examiner for statutory rules has indicated that she has no issues to raise with respect to this SR either. So can I ask if members are content with the SR? So just if members can agree that the Committee for Health has considered SR 2024-106, the Bread and Flour Amendment Regulations Northern Ireland 2024, and has no objection to the rule. Okay, members, item number 9 then, the SR the period products Department of Health specified public service bodies regulations Northern Ireland 2024. If I could refer you to the papers at page 9 or tab 9 of the pack from page 834 and to the clerk's memo at page 2 of your table papers. This statutory rule specifies the bodies within the Department of Health that must supply period products free of charge for persons in its premises who need them. This SR is subject to draft affirmative procedure, and the committee agreed at its meeting on the 21st of November 2024 that it was content with the merits of the policy. The plenary debate is expected early next year, and the SR will come into operation the day after the regulations are made. And the examiner for statutory rules has no issues to raise with respect to this SR. Are members content with the SR? So just to agree then that the Committee for Health has considered SR 2024, the period products Department of Health specified public services bodies regulations Northern Ireland 2024, and recommends that it be affirmed by the Assembly. Okay, then item number 10 is our correspondence. If I could refer you to the correspondence list at page 865. Yeah, no problem, Diana, thank you, and have a lovely Christmas. Page 865 in the main pack and page 6 of your table papers. Correspondence begins at page 866 in the main pack and at page 7 in your table papers. Are members content with the suggested actions at page 865 of your pack? And if has anyone any comments in regards to correspondence and table papers? No? Okay. Item number 11 is the forward work programme. The draft forward work programme is in your meeting pack at page 968. Just to remind members, the committee will be holding informal meetings centred around learning from those with lived experience on Thursday the 9th of January before the Assembly recess. The committee meetings start again in the new year. So if we could refer members to the discussion of the committee's strategic priorities for the meeting of 16th of January as well. This will be an opportunity for the committee to review the work that has been carried out around each priority to date and consider our possible next steps for each priority. Our members are therefore content to note the briefings that's set out in the forward work programme. Yep. Have anybody any other business at this stage? No. Okay, so the date, time and place of our next meeting is Thursday the 16th of January at 2 p.m. in room 29. And just to wish everybody, members and staff, a very happy Christmas and a
Committee Room 29, Sound.